Okay, good morning. Good morning, everybody. Does everybody have their sack lunch breakfast? If you don't, they're outside in the hallway. So before we get started with any of those exciting housekeeping details, and I know the most important question is, what time does the silent auction end, right? So I'd like to introduce Tom Campbell. We're staying at his house here this week from Campbell's Resort.
Thank you. Thank you. Hope you like the basement. Good morning, everybody. I'm Tom Campbell, and I just wanted to... Quick show of hands, who's been to the conference here at Campbell's before? So you're familiar. I haven't welcomed this group in, boy, I think it's been 7 years, but my brother welcomed the last time. And we always like to take a minute to set the tone for where you're at, right? You're at Campbell's, you're at our place, and it's been our place since my great-great-grandfather built it. So we're fifth generation innkeepers, and we know hospitality through and through. We know the industry, but we also know it's a people business, and it's all about showing appreciation, and it's genuine. So we've had, all of us, I know, in this room have had a very challenging, gosh, call it 2.5, 3 years, right, through the pandemic. And so for us to be able to welcome this group back to Campbell's, and I know it's not the first time, but it still is something that I just wanted to highlight is how appreciative we are that you are taking the time out of your busy lives to come to Lake Chelan in October and spend some time with us to get together and to meet face-to-face and to network and to use our facility for that. So it's just, I want to say thank you. Thank you for coming. Thank you for the time. This time is something you never get back. So thank you for spending this time with us and coming and trusting us to host your event, because we really appreciate your patronage through the years, and hopefully it's for another 10 years. So
Actually, I think we're into the 20-something.
My goodness. Isn't that impressive? So
Were we your first company in 1901 to have our...
let me see. A couple things. It's fall. It's fall in Chelan. It definitely is fall. Starting to feel a little crisp out there. If you go up to the restaurant, our kitchen has put together a great fall menu. We have happy hour 7 days a week from 3 to 5. So it's a great place to get up there after some meetings and do some networking. Old school networking up in the bar. Rehydrate. Our team is all here for you. So thank you so much for your time. Thank you so much for being here, and I hope you have a wonderful experience while you're in Chelan. Thank you. Thank you. Thank you very much.
And we thank Campbell's because every year they donate a gift certificate for a free night stay. And thank you for that, Tom. And Hilda and I fight over it. She says, I want it for the silent auction. I say, I want it for an exhibitor bingo prize. And she always wins because, you know, she donates days of her life into putting together our silent auction. So thank you, Tom, without any further hesitation, Hilda, have we figured out when we're ending the silent auction? We don't want to interfere with any sessions, and my goodness, look at the dairy cow schedules, posters. Those guys brought the old school AV materials, huh? Hilda.
Well, good morning, and again, I have to say it's a joy to be here and see everybody and talk to everybody. So I wanted to, again, tell you some of the things that we have at the auction that you may not know about. One of our wonderful nurse managers, Kim, has donated a $50 bottle of wine with an aerator. It's en route Pinot Noir. I don't know how to say that, but it's from the Russian River Valley Vineyard. So she said it's her favorite.
It's not Pinot Gris, it's the other Pinot.
Okay, Pinot. Okay, so we have an Echo show. If you don't have one, wow, it's awesome. You know,
you need one.
Yeah, my grandkids every day go, Alexa, how many days till Christmas? So it tells you everything. So we have a soup extravaganza basket, mystery lovers books, my favorite wines from Washington. There's 3 bottles of wine, chocolates and accessories. Right now, the bid's $20. Yeah, get up there. At the break. So we also have a massage gun. I had to ask my daughter what that is, and she said, we just bought one. It gets deep tissue. So there's a massage gun up there. And also, we're so happy, as Barb said, to have the one-night stay at Campbell's. If you've enjoyed this, the surroundings, the lake, the quaint town, cute shops down there, if you've enjoyed that, consider bidding on the overnight stay, because that benefits our auction and it'll benefit you also. So, I do have some exciting news. Remember we had 2 Seahawks tickets for sale? Yeah. Okay, we now have 2 more. And they're seated right next to each other. And the date of the game is New Year's Day. Everybody's off, okay?
Unless you're on call.
Unless you're on call. And it's against the Jets.
Gregg VandeKieft is working that day.
Oh, no, that was one of my main bidders. So, and I did make a mistake. The tickets aren't 7 rows, they're 4 rows. They're some of the best tickets you can get. So I invite you to bid on those, and it certainly is wonderful to support this organization and have conferences like we're having today. So I'm going to end today the same way I ended yesterday, talking about why we're really here. You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die. Dame Cicely Saunders.
Thank you. Hilda, how many years have you been volunteering to run the auction with your daughter, Mary? I know Meg and I inherited you when we came in 2015. At least 8 years, yeah. Oh, that's right. The 8-year-old who was here in utero is now here in the flesh. Okay, thank you so much. So a couple other housekeeping details before we start our annual business meeting, or as we're calling it, the every 3-year business meeting when there's a pandemic. Meg has sent out everybody a link to an online evaluation, so hopefully you've been keeping up with that. And there are a very few paper copies that we will be auctioning off. And by the way, the proceeds from the silent auction actually go to support the state association. We are a small nonprofit, public benefit organization, so we represent all the citizens of Washington who need palliative and hospice care in addition to the programs and the individuals who provide that care. So any other housekeeping details from the AV corner of the room? Somebody asked me when the link to the recordings will be sent out for those who attended the conference. That's like to be determined. Oh yeah, pressure's on the tech team. Clint had a birthday yesterday and he spent it with us, so he may want to celebrate for a day or two. Anyway, soon that link will be sent out. Yes, Hilda. Oh, no, you were keeping that secret, 12:45. So, and we'll try to make an announcement, with 5 minutes to go so you can dash up with your pen in hand or just hang out up there. And thanks again to our exhibitors and sponsors for helping to support this conference. Yes?
I just thought of something. Maybe there is a board member who would like to help check people out at the end of the auction.
Maybe we have some new board members, and as a rite of initiation, if you are selected to serve, anyway, we'll figure that out, I'm sure. Okay, I am going to introduce again Dr. Kathy Katzenberger, our board president, to get this annual or every 3-year business meeting going. Let's see, is something happening? This happened to me yesterday. Okay. what would a conference be without a little tech issue right off the bat?
You got to go up here. Oops, to
Oh.
slideshow.
Yeah, I thought it was already queued up, but I guess it defaulted.
Okay. Come back, little meeting. Slideshow. From beginning. Clicker. All right. Okay. So good morning, everybody. Welcome to the business meeting. I hope you have been having a great time at the conference. Who's been having fun at the conference? All right. Great. We hope that you've really been enjoying it and connecting with people and just having a great time. So this is a part of we're just going to have a little business meeting for just a little bit. So let's see. I'm going to call this meeting to order, and I'm going to ask Dr. David Burnell to come up as the secretary to do our hospice provider members roll call.
And we'll just stand here and look pretty.
Excellent. Everybody needs backup
Stand
singers.
there and look pretty.
Well, that's a tall order. Okay, so just by way of explanation, we're going to read off the 23 program names of folks who've paid their professional dues this year. There's lots of programs who haven't, and that's no shade. It's just if you're here, you matter. We're happy you're here. But don't panic because we didn't read your name. It's just the annual meeting, and we have a ballot this year. So paid members get to vote. And if your name wasn't read, maybe go back and talk to your leaders and say, hey, it would be a great idea to pay dues to the organization. It was a good conference. Okay, so, and then each of these members that I'm going to read off right now have 1 to sort of 9 delegates. There's one person in each group who is designated the ballot recipient, and you should have had on your badge the word ballot kind of pinned to it. If you don't have your ballot, Meg will get it to you, or you can go out briefly and pick it up, okay? And if you don't know who you are, ask Meg about that too. So we have...
If you don't know who you are?
Yeah, that's what I said.
Hopefully she can help you.
That's right. I'm the secretary, and I get to say what I want. All right. So Astria Health, Central Washington Home Care Services.
Are they supposed to be like giving a shout?
Sure. Astria, are you here? Okay, thank you very much. Central Washington Home Care Services. Anybody here from there? Nobody from the 10 delegates. Okay. Chaplaincy Healthcare. Thank you. Good to see you.
A little enthusiasm. There
That's
we
right.
go.
Community Home Health and Hospice. Thank you. Elite Home Health and Hospice. Thank you. And Vision Hospice. Yes, I know you're here. I saw you earlier. EvergreenHealth.
Yes.
All right. Harbors Home Health and Hospice. Thank you. HeartLinks Hospice. Thank you. Horizon Hospice. Yes, small but mighty. Hospice of Spokane. Smaller but mightier, exactly. Thank you, Gina. I guess you know who's picking up your ballot. Hospice of the Northwest. Yeah. Jefferson Healthcare Hospice. Thank you. Kaiser Hospice? Okay. Thank you. Kittitas Valley Health. Klein Galland? Uh-huh. Mm-hmm. I'll pass on the commentary. Providence Hospice? Scared everybody else away, did you, Stacy? Okay. You did. She's as far away as she can get. Providence Palliative Care? Okay.
Here we are, right here.
Yeah, we know. Seattle Children's Hospital. Thank you, Anne. Virginia Mason Franciscan Health Hospice. Yes. Virginia Mason Franciscan Health Palliative Care. Thank you. Walla Walla Community Hospice. Good morning. And then Whatcom Hospice. Thank you. Okay. Thanks, guys.
Thank you. Let's see, I think I have a slide for this. Let's see. Does it work? Oh, that's the agenda, sorry.
Okay.
Agenda, which is on your table as well. Oh,
I don't think there was a list of the board of directors.
oh, on the slide?
Yeah, I think it was just the.
Yeah, sorry.
Okay, so next we are to introduce the introduction of the board of directors. So I'm just going to ask all of them to stand up. Everyone that's a part of the board, please stand up.
Also, our prospective new board
Yes,
members.
prospective new board members also stand.
So these people agree to get extra emails, attend extra meetings, be on telephone call, get assigned to help sign you out at the auction. There's just no end of the tasks they volunteer for. So how about a round of applause for our
Okay, all right. So now I'm going to ask for any additions to the agenda. Not aware of any additions. Anybody have any? Okay. So now I'm going to turn it over to Barb.
Yes, Gina Drummond from Hospice of Spokane is officially our treasurer. However, she is going off of the board. So as a parting gift to Gina, I volunteered to give the financial report. And really, I just want to provide a summary. As I mentioned earlier, we are a small nonprofit, but you as our members who pay dues are entitled to know what sort of financial position we're in. So these financials are through September 30th, and you'll see our year-to-date income and expenses compared to what we had budgeted. And of course, last December, when we were creating the budget for 2023, we really didn't have an idea if we were for certain going to be able to have a conference or not. And the reason you'll see the year-to-date net income, our actual is $52,000, a little over $52,000, and the budget was $76,000. Actually, the conference income had been rolled into that the budget, even though we did get additional conference registrations and exhibitor payments in October. So don't be alarmed that our year-to-date net is so much lower than what we had budgeted. And I think the most important thing is really at the bottom of the screen. Our total assets are about $253,000. So we have sufficient revenue to keep in operation, and it's always our goal to finish the year a little in the black. We're not out to make a big killing. You know, we don't have private equity firms rushing us to invest in our state association, but we want to make sure that we have sufficient revenue to fund our operations. So I'll just ask if there are any questions about the financial report. This was also shared with our board at our board meeting on Sunday. Any questions, comments? Anybody want to make a donation? Go up to the silent auction room.
Okay, next is time for our membership vote. So each provider member receives one vote, and I think Meg has already passed those ballots out. So programs that are not present for the meeting can vote electronically. And we'll skip.
Yeah, I can take it.
Yeah, okay.
So we have a number of current board members who have agreed to run for another term because they're having so much fun. Our terms are 2-year terms, and board members are limited to serving 4 consecutive 2-year terms. If they're having so much fun, they don't want to step away, and then they do have to step away for a year unless we have a need. And we've had some open positions in the past where we've made an exception and had a board member stay on for an additional year or even a full 2-year term. And so these are the current board members who have asked for your consideration. Again, they're people who agree to get extra emails and attend extra meetings, et cetera. And then we have our prospective new board members who are asking for your consideration because they've agreed to attend extra meetings and to get extra emails and go through policy reports. And for example, Leslie Emerick and Meg and I don't do anything without our board's approval on behalf of our state association. So those are all of our prospective new board members. I believe you have on your table or you've been emailed the biographical information. And if you're ever interested in serving on the board, please let us know. We're always sort of recruiting folks. Stacy's like, yeah, sometimes you're sorry you said yes. But anyway, no, she never would say that, so no. But Stacy you're our current vice president, right? And she wholeheartedly nominated Kathy to carry over another year as president. So because Stacy's like, no, Kathy, you're doing a great job. Sign up again. So anyway, those are our prospective new board members. And now I'm going to run through some bylaws update. Oh my gosh, Marie, that's terrible font size, isn't it? So you have this material as well, or it's been emailed, right, Meg? So really what we did was go through the bylaws and update, edit some language if it was unclear. And I'm going to give you an example of that. So this was just some basic cleanup. There's nothing major here. Qualifications of directors. There was just some lack of clarity. And especially for Meg and me coming in, and now it's been 7 years ago, we didn't always know what was meant by some of the language. So this is an example of extra work that the board did. In a couple of separate meetings earlier this year, we went through the bylaws and made it more clear. And let me see, terms of office, there was some confusion about that. So again, these were just mostly minor edits. And here were two more substantive changes, and I just wanted to point them out to you. So it wasn't clear in the previous bylaws language who elected new board members. And some board members had in previous years thought, well, it's the board who elects new board members. And Meg and I asked the question, well, should it be the members who elect new board members? And the board agreed with that. So we're making that more clear in the bylaws, that it's the provider members who elect the board members. And then compensation of directors, we clarified some language about reimbursing for travel expenses in the rare occasion that we do have an in-person meeting, and added the small token of appreciation that if we do have a board meeting in conjunction with the conference, then the board members would be able to attend that conference at no cost. And I'll tell you what, we asked most of them to present anyway, so they would have gotten a small discount for presenting, but we thought this was a small token of appreciation for all of the time they put in behind the scenes putting on the conference. So I think that's really it for our bylaws changes. So we ask again one representative from each provider member program to vote on those bylaws. And you're happy to add comments if you want for the board to consider for future bylaws changes or more clarification. Any questions from anybody? Yes.
I'm not sure I understood. I don't have anything about the bylaws on the ballot. I have only
Okay.
the board on a board ballot.
Oh, gotcha. Okay.
Can we do a vote?
Oh, in the room. All right. So I will defer to our board president to call for a vote then.
Okay, so we're going to call for a vote on the bylaws. Does anyone make a motion? Okay, do I have a second? Okay, all those in favor? Say aye. Any opposed to the changes in the bylaws? All right, it's so passed.
Thank you, Meg.
Our next part is, once again, our Stu Farber Award winner, Leslie Emerick, is going to come up and give the committee reports.
And let's have another round. Leslie has a few slides.
Yeah, you guys are really spoiling me this year. I'm still in a little bit of a shock, so. Oh. There we go. So I just want to tell you there's a number of different ways to get involved in public policy, and I'll be talking about it a little bit more in my presentation. But we have 3 public policy committees that I help run. The first one is the Public Policy Committee. Oh, wait a second. How do I change the... There we go. So the Public Policy Committee, we basically... Uh-oh.
It's just you.
Just me? I'll let Meg work on that, and I'll talk about the Public Policy Committee. So every month I put out a lengthy report because there is a lot of stuff that goes on in state regulations. I monitor all the things that come up from the state agencies, from the Healthcare Authority, the Department of Health, sometimes employment security, you know, it just kind of depends what the issues are, L&I. And I compile those into reports, and strangely enough, it still adds up to 8 to 10 pages every month of just all the different issues that we're tracking as an association. So a lot of times at the board meetings or executive meetings, we don't have a lot of time to talk about those issues. It's boom, 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 this is what's happening. The Public Policy Committee gives us an opportunity to talk about them in more detail, get more feedback from our membership, and if we have recommendations in the Public Policy Committee, then we take those to the board, and they can take them or not, you know, but at least we're trying to gather more feedback from people. So pretty much anybody's welcome to join the Public Policy Committee if you're a member. You know, sometimes we have a good turnout, sometimes there's 4 or 5 of us, so it just depends, but I would welcome you to join us for the Public Policy Committee. The next committee is the Pediatric Palliative Care Committee, and when I get the slides up, it'll tell you when those meetings are. And actually, Meg's done a good job. If you go out to our website, you'll see all of our meetings for public policy and pediatric palliative care work group and that sort of thing. On the calendar. On the calendar. There we go. So I'll go ahead and go to the next one now. There we go. There's our pediatric palliative care. So, you know, this committee's been around for a very long time. I inherited it when I became the public policy director, but the first issue that we found is that concurrent care, nobody was doing it in Washington State. And we're like, well, why is that? It's in the Affordable Care Act. So we went back to the Healthcare Authority and took a closer look at the rulemaking, and it said that the kids have to be able to return back to a normal state again. Well, there's no kids in pediatric palliative care that are ever going to return to a normal state again. And I don't know how they came up with that years ago, but we set about right at that moment to change the rulemaking. And now, I don't know how many pediatric palliative care or concurrent care referrals we get a year, but it's pretty significant. So that super changed the way that our pediatric palliative care, and that's where I got to know Dr. Brunel better and Ann Anderson. You know, we started to team up to really work on these issues. We went down to the state, we testified at public hearings, and we made that change. And now kids in our state have access to concurrent care. So that's just an example. Also, our one of the things I'll be talking about more later, our pediatric palliative care rate, you know, that came out of this committee too as a recommendation to the board. And then we have palliative care networking calls. So we also have a planning group. This basically happens every other month. And we've had some super interesting topics like the role of psilocybin and other psychedelics in palliative care and hospice. That was an interesting one. You know, there was a piece of legislation, a budget proviso, that established a committee in the legislature this year just to review this issue of legalizing psilocybin for healthcare purposes. We had one in March on VSED. Barb and I talk on a regular basis on rulemaking for palliative care and just give updates on the programs that we're having that impact palliative care. And then the one that we had in September was integrative approaches for palliative care. And then we've got another one coming up with our friend Pat Justice, who I'm always thrilled to work with, on November 15th, funding models for palliative care. So we do take a little bit of time off during the summer, but anyway, I would really invite you all to get involved in these programs. It's a really great way to learn what's going on, get your feet wet, understand the process a little bit more, and, you know, eventually make change. So thank you.
Yeah, so we're a little bit ahead of schedule.
I'm going to take shameless advantage of having you all captive in the room. So one of the things we're trying to decide about are palliative care networking meetings. They've been taking place at 7:30 in the morning on the third Tuesday of the month, or every other month. And Leslie inherited that schedule. And sometimes we'll have 20 people attending, and sometimes we'll have 5. And so we're trying to ascertain if it would be better to change the time of day, if 7:30 is just a little too early for some folks because you're actually driving to work or you're getting kids off to school or whatever it might be. So just by a show of hands, if we were to say have choices between 7:30 and lunchtime, not necessarily on that day, but during the week, or at the end of the day. So just decide amongst those 3 if you were going to attend this meeting to learn all about a topic of interest in palliative care. Who would prefer to keep it at 7:30? Show of hands. All right, lunchtime. More towards the end of the day, like 3:30 or 4. Oh boy, it's close between that. So we will send out a poll to all of our members and ask you to vote on those 2 options, lunchtime or more towards the end of the day, because we want our participation to increase. And if somebody's gone to the trouble of creating a set of slides and a presentation for our members, we'd love for them to have more than 4 or 5 people there to attend. So although Leslie does send out the recording and the slides later, but we will send you a poll. All right, I'll turn it back to you, Kathy. And I think the only other slide is our adjournment slide. I don't know that we need to change for that.
No. So should we give a break before Leslie starts?
I guess we're 5 minutes ahead or 7 minutes ahead of time.
So we could give a,
When people are done voting, maybe bring your ballot to me, I guess?
You could ask if people want to show break.
okay. Okay. Okay, I'm going to adjourn the meeting, but what I want to know is you guys want to have like a 5-minute break because we're just a little bit ahead of the schedule. Who wants a break? Okay, we'll just give you a 5-minute break. We'll start very promptly at 8:40. Thank you. Okay, everybody. It's 8:40, and it's time to get going. So I get the pleasure and honor again to introduce Leslie Emerick, who has 26 years of public policy experience. She has an MPA, and she has represented WSHPCO since 2007. She started as a lobbyist and now, of course, is our Director of Public Policy and our Stu Farber Award winner. She was a Douglas County Commissioner and a legislative liaison for the State Department of Agriculture and Department of Health. She has a Master's of Public Administration degree, a BA in Speech Communication, and secondary education with a minor in political science. Leslie started her contract lobbying business in 2006 and currently represents multiple healthcare-related associations. So let's give it up for Leslie.
Thank you, thank you. Well, it's really exciting to be back here again. It's been a number of years, and I went through my slides and I thought, gosh, what would be a good slide for Lake Chelan? Oh, there's a Lake Chelan slide with a rainbow on it. And when do rainbows appear? After the storm. So I feel like this was a really appropriate one. Not only are we after the storm, we are also, I think this is a symbol of hope for us as well. So I want to start out with this. Start by doing what's necessary. then do what's possible. And suddenly, you're doing the impossible. And I just want to thank everybody in this room for all the work that you did during the pandemic and continue to do. It was a trial by fire for everybody, not having enough PPE, all of a sudden to have to go to telehealth and telemedicine like you've never done before, trying to get to people's homes, the controversies over the masks and the vaccines and everything. And hey, you survived it, and here we are, and I'm so happy to be with you here today, and I'm so proud of all the work that you did through this really, really difficult time. So even though we're really kind of tired of talking about COVID, we really can't stop talking about COVID because COVID really isn't totally over yet. One of the things that we're left with is that it totally exacerbated the workforce shortages for nurses and CNAs, and I'm sure every one of you in this room are feeling that. We had supply chain shortages. We had increasing costs. We have difficult to discharge patients that are backed up in hospitals, and as you know, some hospitals are actually on divert status right now. So we're in really, really tough times. One of the reasons that the hospitals are on divert status is because the skilled nursing facilities are full, or they can't get certified nursing assistants in there to work in them. We even have hospital beds right now that are open, but we don't have enough staff to serve them, so even though we have the physical capacity for it, we don't have the staffing capacity for it. And then, anybody who's been to an emergency room lately? Oh my goodness. I took my dear mama in about a month and a half ago, 8 hours outside in a wheelchair with a blanket over, trying to get into the emergency room. And there were people that were filling the hallways. I mean, it is a really, really difficult time in the hospitals right now. So there's a few things that are happening as we kind of wrap up the end of COVID emergency orders, and Governor Inslee has announced the rescission of all remaining COVID orders, except one, which isn't under him, and I'll talk about in a minute. The vaccination requirements for healthcare and education workers will end, but employers, your employers, may still continue to request that you be vaccinated, so that will be a policy choice in your organization. And he's also said that vaccinations will continue to remain a condition of employment for most Washington state agencies. So that's still in place. The piece that's still in place regardless is masking for healthcare providers, and that is still required by the Secretary of Health, Dr. Shaw. So masking will be in place for quite a bit longer. And then, as Barb always reminds me, CMS has different orders than the state of Washington. So I would say, make sure you're following them too. And she can tell you what those are, because I track the state issues and she tracks the federal issues. But we are starting to wind down. One of the things that's been really interesting the last 2 years in my legislative world is that we've had 2 virtual legislative sessions. And that means all of the public hearings were online. And as with most virtual meetings, you'll see one legislator in there, an old frame with her baby. You know, I mean, everybody likes, I think the one thing we all kind of enjoy is seeing people's babies, children occasionally peek in, or a cat or a dog or something like that. Barking dogs don't, you know. And in the legislative one, and an occasional flush of a toilet. So I guess they forgot to turn their sound off, you know. I'm sure it was a little embarrassing for them. But this next legislative session, you know, I'm understanding it's going to be part virtual, but there was a silver lining for some of the virtual sessions, and that is that we had record participation in the legislative process for the last couple of years. So it used to be if you lived in Spokane and there was a public hearing coming up and you wanted to come over and testify and your testimony was for 3 minutes, you'd have to spend 2 days driving over from Spokane, perhaps in the middle of a snowstorm, get to Olympia, probably have to spend the night, and spend that kind of time and money. And then during this session, last 2 sessions, we've just been able to call in from anywhere in the state. And to me, that was a huge, huge benefit. And I believe that, you know, the legislature really recognizes what a benefit that was, and that we're going to see the ability for people to sign in remotely this next session. So 2023 session's coming up here. It's the 105-day long session of the legislature. In the even numbered years, they have the short session, and that's only 60 days, and I'll explain why. We have a 2-year biennial legislature. So that means bills that are introduced this next year will last for 2 years. They also put together the operating, the capital, and the transportation budgets, and those are huge. So those are based on revenue forecasts that come out that says how much money the state's going to make, projected sales tax revenue, and that sort of thing. And they say, okay, we've got this much money to spend, and they put together their budgets. There's actually 3 budgets that come out for each of these. So the governor has a budget, the House has a budget, and the Senate has a budget. And they all have to agree in the end on a final compromise budget. So that's, why it takes 105 days to work through the legislative process so that everybody's in agreement about what's going to be in the big budgets for the next 2 years. Just the lay of the land in the legislature as of today, because we have an election coming up. The House of Representatives has 41 Republicans, 57 Democrats. The Senate has 20 Republicans, and they've had one Democrat caucusing with them for many years, Tim Sheldon in Shelton area. Say that 3 times. And he's actually retiring this year. He's been in the legislature a long time, and there's a new person that's running for his position. And there's 28 Democrats, and of course Governor Inslee is a Democrat. So the legislature right now is run by the Democrats, and hopefully we'll see what happens this next year. So it is an election year. How many of you are sick of the ads on the TV? Ugh. They're so creepy. At any rate, all 98 seats in the House of Representatives are up for election. So the entire House turns over. That means that some people run for re-election, some people have retired, some people that were in the House are running for the Senate, but there's about a third of the legislature turns over during any particular election year. Half the seats of the Senate are up for election because they stagger those so they don't throw them all out at once to have to rerun again. And then mail-in ballots have been sent out. So I would say, please remember, bad politicians are elected by good citizens who do not vote. So yes, please, please vote. There's a lot of important issues. I think this is a game-changing election, whichever side you're on, which team you're on, it's a big election. So please don't let those mail-in ballots go into the recycle bin. All right. The next one, the legislative session. I just want to remind you that the legislative session is held during the dead of winter. So when you go up there to the Hill, I've been up there in ice storms with, electrical wiring down, and they're still going. In all my years of doing this, which is around 25, I've only seen them shut down the legislature one time because it was too dangerous for people to come to the Hill. So, it's an interesting environment to begin with, but when you're in the middle of a snowstorm, an ice storm, that just adds a certain element to it. So the pieces that we're working, our highest priority this session was expanding palliative care in Washington State, and I'll describe how we were going to do that, and addressing the workforce shortages. I'm going to take a drink of water. So we were successful in getting a $250,000 budget proviso put into the state operating budget to design a standardized payment methodology for a palliative care benefit for Medicaid and PEB and SEB. So PEB is a Public Employees Benefit Board, and SEB is a State Employees Benefit Board. This will expand palliative care to approximately 2.65 million people in Washington State. Yeah, this is huge. Now, I will tell you that this did not magically happen overnight. So we have been working with the Healthcare Authority for many years. We were doing rulemaking with them probably about 3 or 4 years ago before the pandemic hit. And then, of course, most state agency rulemaking came to a screeching halt because people were pulled off of their regular jobs at Department of Health and other healthcare agencies to work on pandemic-related issues. So basically, that palliative care rulemaking died. So last year, as a board, we were talking about, well, maybe we should run a bill that says thou shalt have a palliative care program with Medicaid and PEB and SEB. So we had this big meeting in December last year before the legislative session with the Healthcare Authority and the governor's office. And we talked to them about the fact that we were thinking about running legislation, and I had Dr. VandeKieft on the phone and, you know, a bunch of luminaries in our palliative care world. And we started giving our presentation about how wonderful palliative care is. And Dr. Teresa Fontanos, who's the Medicaid director, about 10 minutes in goes, okay, stop. She goes, I get it. You don't have to sell me on palliative care. We will do it. We will do it. And I said, okay. We were so excited to hear that. And she says, you don't need to go to the legislature and have a bill that instructs us to do it. We will do it. So I said, okay, what we'll do is we'll go to the legislature and we'll give you enough money to help you start the program and get the program off the ground. And she said, deal. So when we went to the legislature and asked them for money, at first they said $250,000, and then they changed their mind and said, oh no, with PEBA, we're going to need $600,000. Well, the legislative staff said, no, you're going to get $250,000. And they're like, well, then we're only going to do a certain portion of it, and we're not going to implement the full benefit. So we have to go back to the legislature again, but what I'm working on right now is to try and get that in the governor's budget, because it's in the legislative world, you know, $300,000 is not a ton of money when you're talking about a $52 billion budget. So we're trying to get that in the governor's budget so that we don't have to come back and, you know, work it as hard. It still has to be passed through the legislature and all that, but at any rate. And then I sent Barb a note last night because I just got a notice that they're beginning the stakeholder work with the Healthcare Authority for the palliative care benefit. And it's kind of interesting. They're talking about doing individual interviews with people. Well, you know, I'm great on the policy level, but I'm not a clinical person. And I'm like, can I bring Barb with me, please? So I would imagine some of the other folks in this room will be getting that notification as well. Can you let me know if you get a notice from the Healthcare Authority to meet with them? I think it's interesting that they're not pulling us together as a stakeholder group, that they're having individual meetings. So I'm not sure what that portends, but at any rate, I'm trying to get them the money in the next year's budget for it. So the legislature invested over $50 million in the workforce. And as you all know, hospice nurses are angels. At least everybody tells me that, and I believe it, of course. So they did add a number of nursing slots to various colleges around the state. So 220 nursing slots for 2023 and 270 thereafter. So this went to the nursing programs at UW, community colleges, Eastern, Western universities. They got money for nursing student loan repayment for nurse educators, which has been a huge bottleneck, people to actually teach nurses. And then the Department of Health has hired 10 more people to expedite nurse licensing process. So probably many of you experienced during the pandemic that you weren't able to get nurses from other areas or maybe even graduate students because they couldn't get their licenses processed through the Department of Health in a timely manner. So that was huge. Then we've been part of the Long-Term Care Workforce Steering Committee, and that is also about NAR and NAC training. And they tried to come up with a standardized curriculum for people being able to move between different healthcare settings. So as you can see, I'm up there in the upper right-hand corner, little picture of me up there, but I've been on that committee for about 4 or 5 years. And they just started new rulemaking to talk about implementing this standardized curriculum for certified nursing assistants so that they'll be able to work in a lot more different settings instead of just maybe a skilled nursing facility or home health. They're getting a little bit more training in various different areas. From the last legislative session, there was a Death with Dignity barrier survey. Basically, they're trying to find out what barriers there are to Washington State to achieving full access to the Death with Dignity Act. And probably a number of hospices in this room also received a copy of that survey. So, you know, it would probably help if you could fill it out and send it back in to them. We've been involved with the Dementia Action Collaborative for many years, and my role on that board, and I was appointed by the governor, represent our association on this particular committee. We developed the Washington State Alzheimer's Plan. You might find that the Dementia Roadmap looks very similar to our palliative care roadmap. There's a good reason for that. So the Dementia Roadmap came first, and it is an excellent tool. And my job has always been, well, what about end-of-life care? What about hospice? What about palliative care? So, you know, my job is to make sure that those things get in these booklets and are addressed on some level. Even in the curriculum for the nursing assistants, you know, I got them to add end-of-life care to their training modules that they were doing for the nursing assistants. So, what are our 2023 legislative priorities? Well, first is to get that remaining portion of the budget proviso into the state budget one more time to, you know, fully fund the palliative care effort. The other one is to increase Medicaid palliative care reimbursement rates, continue to address the nurse fork shortages. And I will say that there's over 2,500 bills introduced during a legislative session. We typically track about 40 or 45, but I still have to look at every bill title. Then I pull out which ones I think are going to impact healthcare in general, and then which ones specifically I think impact hospice and palliative care. And then sometimes that changes what our legislative priorities are for that session. So the palliative care benefit that we're working on with the Healthcare Authority, really the main goal is a standardized palliative care benefit. So how many of you fund palliative care through a patchwork quilt of pulling a little money here and a little money there and, yeah, trying to piece together what a palliative care benefit looks like? And also, you know, we've worked a lot with the rural palliative care team. And I mean, funding is the #1 issue for not being able to get palliative care pulled together. So we just want a standardized billing method, you know, a code, something that the state says this is palliative care and you can bill for it under this particular benefit. So really that's our goal. That came out of the BRE Collaborative Palliative Care Work Group. If you haven't looked at that, there's a whole report that we were also the proponents of in the BRE Collaborative Palliative Care Report. You can just Google that. And it's a really extensive report. And again, Gregg and others were part of that group that helped develop a plan for the state of Washington about how we could implement a palliative care benefit. In the pediatric palliative care reimbursement, we haven't seen a rate increase for over 14 years, and actually I think it's been longer than that, but they apparently don't have records that go back before 2006 on this particular issue. So you can see that the rates have been stuck anywhere from $77 to $88 in that range for all these different counties in the state. And we're saying this should have been raised a long time ago. They're telling us it was tied to the hospice benefit, but hospice goes up with Medicare, and they've never increased this. So that's a further conversation we're going to have with them. But we want it to at least match the home health benefit, which has been incrementally going up over the years because I work for the Home Care Association of Washington, and we also get rate increases through them for helping out with home health. So the Department of Health has a decision package, and it has both policy and budget requests that they send to Governor Inslee. They are a cabinet agency of the governor's office. That means the governor appoints the Secretary of Health, and pretty much all the big policy issues have to be run through the governor's office. On some level, they have to get support and approval. And if it really works out well, all the things that it's in their decision package ends up in the governor's budget. So these are the things that they're proposing. One is establish a statewide medical logistics center, which I think is great, so that they have a 60-day inventory to respond to disasters and health emergencies. I think they were looking at 7,500 or maybe 75,000 masks. Anyway, to have the supplies that you need, so we'll never be in a position again where if there's a pandemic or an outbreak that we don't have access to what we need. Next was to develop a statewide medical reserve corps. Some of you had the National Guard in your facilities during the pandemic because we didn't have enough staff to be able to handle the overload and providing shots and all that. So they're training up volunteers and equipping them for this medical reserve. The Uniform Facilities Framework means that they're establishing a standardized framework for enforcement, and that's going to include in-home service agencies. Not so much in the hospice world, but sometimes in the home care world, we get some bad actors out there who it's very difficult to get their license away from them, even though, you know, their transgressions are great. So this just gives more tools for the Department of Health to be able to go in and, you know, get those people out. The next one has to do with home care aides and agency-affiliated counselors. They're going to get $8.2 million in debt erased. So the O2G fund is all of your licensure fees from nursing, PT, and everything goes into this big fund called the O2G fund. And from that, they fund all your boards and commissions, like the nursing commission, the PT commission, the OT board, you know, all those things. And then they find out, well, how many investigations, how many complaints, and then they charge, you know, your licensure category for those things. So the home care aides couldn't come up with enough money in their licensure fees because they're one of the lowest paid, you know, healthcare workers. So they're going to increase their rates, but they're also going to try and eliminate their $6 million in debt because there's no way they can cover that again. And then there was some funding in there for the Death with Dignity Act to cover the cost of collecting data for that program. The Healthcare Authority just put out their decision package about 2 weeks ago, and there was something interesting in that as well. So as I talked about earlier, hospitals are really backed up right now with difficult to discharge patients, and Barb and I and people from the Home Care Association were involved in initial discussions with the governor's office about how can we help to get these difficult to discharge patients out of the hospitals. We thought that there might be a role for hospice as well, but it didn't fit as nicely as home health. So skilled nursing facilities, obvious, but home health agencies also got some funding during that time period. So now they're thinking, gosh, maybe we should raise the Medicaid rates so that people want to take our clients out of hospitals and into home care. What a concept, huh? So I know that there's some people who only take a certain percentage of Medicaid patients because it will bankrupt their business. So we're working on that. And what I really liked about it was that they were talking about permanent structural rate changes to ensure timely discharges. Wow. I'm not sure what that means, but we'll see. To me, that was hopeful. So our public policy realm is a little bit different than our legislative realm. And one of the things I forgot to mention this morning, we also have a hot team during the legislative session. So as I said, 2,500 bills come out. We probably, you know, I might end up reviewing like 80 bills, but not all of those make our tracking list. And then when those bills get introduced, we only have a week to make a decision about what our position is on that bill. And that means we got to get somebody lined up to testify, you know, we got to get our ducks in a row quick. So we have, you know, the hot team, I call it, during the legislative session. It's usually about 3 or 4 of us, a lot of it's board members, but people that are knowledgeable and engaged, participate in the process. And then we make a determination what the position is. If it's really controversial, we'll go to the board and say, what do you think? If we're going to oppose this, here's the pros and cons of that, you know, or support it. So for the most part, you know, we do run stuff past the board, but some of them are pretty easy that, you know, we don't really need to have a big vote on the board for them. So one of the things that we've been working a lot on in the last couple years actually is certificate of need. And I had all these slides, and I still do, on certificate of need, but I thought, does everybody in the room know what certificate of need is? Maybe, maybe not. Just in case, it's a regulatory program over at Department of Health that requires certain healthcare providers to get state approval before building certain types of facilities or offering new or expanded services. So if you're a healthcare provider and you're in one county in the state or maybe 2 counties in the state, but you want to go to 3 other counties that are around you, you have to go through the certificate of need process to be able to expand into those other counties. And as you can see, I'm not going to read them all, but it affects a long list of folks, including hospice agencies, home health agencies, and hospice care centers. I need another drink of water, excuse me. I've been yakking a lot. Okay. So there's 2 different Department of Health rulemaking that's going on right now, and one of them has to do with the methodology, and this is something that Chris McFall has been our lead on for many years, and I wish he were here to explain it to you in more detail. But basically, the numbers are skewed right now in how the department interprets them, and the proposed rules are going to fix this particular problem. So there's draft rulemaking in place right now. It has to do with the ramp up after the 3-year average for hospice capacity and the way that they're using it for hospice admissions. So that issue is going to be resolved, and Chris had a special meeting with us and the Department of Health and actually got them to see what the issue was by taking their methodology, circling it in red, pointing an arrow to it and saying, the mistake is here. And they went, oh, okay. And within a day, they sent out a revised version with what he had pointed out to them. So really, that's how we work together as a team. That's how we make change. Another thing that's going on is that they're having listening sessions. So we're fixing this little teeny piece of certificate need of over here, but they're also looking at the big picture. And I've been talking to our folks. We've got 2 more listening sessions coming up, one on November 1st and January 3rd. If there's any more changes in the hospice certificate of need, now is our time to tell them. And one of the big issues that we have is that some of our hospitals are not taking children and not serving children in their communities. And that has been specifically laid out by the Certificate of Need Department for some time. People used to get letters saying, no, you have to take care of children as well in your Certificate of Need area. And they would get letters from the Department of Health around this. Well, there's been staff changeover, a lot of things have happened. So we're going to go back and talk to the Department of Health some more about this, but we are going to put in some more specific language in the WAC about when you take over an area, that means you take over the entire population in that area and not just adults. So we'll be working some more on how to firm that up. Also, if you were a facilities that went into a new area during COVID because of the flexibility of the COVID waivers, you either have to get in or get out. So if you haven't filed the paperwork by October 27th to let the Department of Health know that you want to expand for real into that new area, then you need to go back to where you were beforehand. Not a lot of agencies went into new areas, but there were a few around the state. And as I understand it, most of those people have applied to extend their certificate of need into that area. Let's talk a little bit about this certified nursing assistant shortage that's really kind of screwing everything up. So we had 5,000 nursing assistants needing skill testing to get certified. Well, one of the things that became clear to me was that actually CNAs are under CMS. And I think a lot of that is because of the nursing homes and the regulations between the nursing homes. So CMS was the one that was actually requiring that they get their skills testing done by like the end of October. Well, we had 5,000 nurses that got trained during the pandemic, but were never able to take their skills test. So the state and the governor's office and everybody ramped up, and they also went back to Washington, D.C., and they talked to CMS. Well, CMS was able to extend that deadline until March, which is great news because that gives these people more time to get their skills testing. But in the ramp up, they've got 18 community colleges around the state became testing sites for certified nursing assistants. CMS expanded the deadline till the 29th, and we're still not there yet, though. I talked to a friend of mine who owns a certified nursing assistant school in Olympia, and she said, yeah, we're still, getting people graduating from our school, but those nursing slots and those facilities for testing fill up like that. And she says our folks still can't get tested. So they haven't fixed that problem yet, but at least they're trying to address it. And hopefully those 5,000, nursing assistants that are now being able to fully work out into the system again will take some of the pressure off. But this is a real problem that needs to be addressed. I don't know if the legislature is going to do more to address it, whether we need to ramp up more. I've heard that there's some issues with the testing company as well, but this is one of the major bottlenecks that's causing the shortages out there for us. Nurse licensure fees are increasing, so sorry to tell you that to all the nurses in the room, but those additional 10 people that they got during the legislature authority to hire to, stop the backlog of nurse licensure, it has to be paid for out of that O2G fund. And you have to cover the costs of your program, so that's why nursing is getting additional increases to their fee, is to cover the 10 people at Department of Health to process stuff. Another thing that came out of the legislature, these are all like rulemaking at this point. So once a bill passes the legislature, it becomes state law signed by the governor, and a lot of bills need additional clarification, and those go out for additional rulemaking in the state agencies where they further clarify what was in the bill. And one of those was health equity continuing education. So by January 1st of 2024, anybody who is subject to continuing education requirements must complete 2 hours of health equity training at least once every 4 years. So the Department of Health is going to have some classes online for this. It shouldn't be too difficult to do. Hopefully they kind of change it up every 4 years to make it a little fresher for folks. And as I've talked to our board, this could be an opportunity where we have a breakout session where we have, 2 hours of training where people can get their diversity training here at the conference as well. So more to come on that. And you see all the different things that will be included in that. Home health and hospice telemedicine supervisory visits. This is a little misleading, as Barb reminds me that really CMS hasn't changed the rules that would allow hospice to do this. But when they went in to do this rulemaking, our private duty nursing agencies that take care of medically fragile children were able to do these telemedicine supervisory visits, and it really, really helped them, especially kids that are in rural areas and that sort of thing. And we had no safety issues around it. So they went ahead and did the rulemaking, and they said, well, let's do home health and hospice. So in the future, if CMS allows you to do this, you will be allowed to do telemedicine supervisory visits in the future. And that rulemaking was just completed. So I don't know if everybody in the room was here yesterday to see Pat Justice's presentation and her panel on the Palliative Care Initiative. We have 2 cohorts that are operating out there, and total of 13 different communities right now, and I hear cohort 3 sounds like it's on its way. So this is a fabulous program. Dr. VandeKieft is the medical director for this group, and it's a little out of my purview, but I've listened into a number of these consults, and I can't tell you how powerful it is to listen to these people with these super complex cases that are way up in the mountains somewhere, and they're talking to them and they get this incredible feedback from all these experts in the field that help these people in these teeny little tiny rural communities to have access to that wealth of information. It is really powerful, and they are so grateful for that information, and this is a super good program, and we'd like to help Pat continue this program in the future if we can. All right. I put copies of the Palliative Care Roadmap on the table for everybody. So if any of you haven't seen this before, this was also something that came out of our hospice board about 3 years ago, and maybe longer. And we decided that the Dementia Roadmap was such an excellent tool that we wanted to put together a Palliative Care Roadmap too. These can be ordered online, and the information on the back there is who you contact to be able to do that. They are free. I would encourage you to stock up. They just reprinted a bunch of them, so they've got a lot of them in stock there. We've got some more on the table, so I'd love to see that we don't go home with any of them, that you folks take them and for your programs and stock up while you're here. So it's been a fabulous tool for people to be able to use when somebody's been diagnosed with a serious or life-threatening illness. One of these pieces impacts employees more than it does employers, but you're going to start being charged for the Washington Cares Fund, which is long-term care insurance. And what they realize is, of course, baby boomers, and I'm sure there's a few of us in the room, myself included, a lot of people didn't plan for long-term care. So they're entering our system right now and really kind of overwhelming the system because they don't have any other insurance other than Medicaid. So really this is for people that are younger, that are starting to put money into the system right now, that they'll have a cushion of $36,000 at the end of 10 years to try and stay in their homes longer for things like home care, meal delivery, assisted living, or any other needs. Now, we all know that's a drop in the bucket. But if you just need some adjustments to your home or some short-term home care and that sort of thing, that keeps you from going into the state Medicaid program and gives you a little bit more flexibility to try and stay in your home as long as you can. So this has been a little bit controversial. They had to delay it a year because what about people that are in the military or move out of state? And there was a bunch of things that came up that they needed to clarify. And they did, but this is going to start, you're going to start making contributions on July 1st, 2023. So employers will have to set that up in the system, but employees will have it taken out of their paychecks. So how can you get involved? Well, we talked about all those public policy committee meetings that are out there. So really, I'd love to have you more engaged in those. We have an in-home services day on the Hill. It may be virtual again this year. We're going to send out a legislative alert now and then that says, hey, contact your local legislator because there may be a bill that pops up that says, you know, hospice will do this, that, and the other thing, and we're going to go, no. And then we need you to call your legislators and say, please don't pass this bill. And we'll help you out with talking points and those sorts of things. Or please support this bill. It could go either way. But please respond to those. And I would really, if you can get a chance to meet your local legislators, it is so important. So our in-home services day is going to be, February 1st. So much for adjusting slides at the very end. February 1st, we usually start at 7 in the morning because I have an orientation and I talk about our talking points. We have what I call a song sheet, so we're all on the same page, giving the same message to legislators. We did it virtually last year. We had over 50 meetings with legislators. And we do it with 2 other associations. So with the Home Care Association of Washington and the Washington Home Care Association, which is the private duty people. I know that was confusing what I just said. But anyway, we do it with 3 different associations. And it's a lot of fun. If we do get to do it on the Hill, it's great, but there's just some things going on with the legislature and security issues about having to have a ledge assistant come down and get you that might make it really difficult to do this year. So we may go back to virtual. We'll see. In terms of developing a relationship with your legislators, you can set up a meeting at your office and invite them. Community Home Health and Hospice would do that pretty much every year, and we'd have the local legislators come, and it was a fabulous opportunity to get to know your local legislators and to visit with them in your setting. You can contact them by email or by phone. They love hearing from their constituents. I mean, they like me, okay, I've been around a long time, but they love you. So they would really like to hear from you. And while you're at it, thank them for all their hard work, because it is not an easy job being a legislator. It requires a lot of research, a lot of policy decisions. You have to do your homework. They have to show up during the dead of winter to make this all happen. So it's a huge, huge job for them. And a lot of them have jobs that they do when they're not being a legislator. So this is a second job for a lot of them. And I would just say that local advocacy works. How are we doing time-wise, Barb? Well, then I'm going to make this quick. Here's your homework. Get out your phone or your computer at some point here in the next week and Google Washington State Legislature or go to leg.wa.gov. I want you to enter in your home address, not your work address, your home address. I want to find out what district you're in, who your legislators are, read a little bit about their biographies. Are they on the healthcare committee? Are they on appropriations? Because it's like winning the lottery if you've got a legislator that's on the healthcare committee, because they make decisions on, you know, things impacting your policy. So at any rate, see if you have anything in common. Just start to get to know them and get tuned in. And while you're at it, just look around on the Washington State Legislature site. You know, there's just all sorts of information you can get there. And you can even track bills yourself from there. So I want you to act as if everything you do makes a difference, because it does. Thank you.
Don't go anywhere. So for those of you who didn't know who Leslie Emerick was yesterday morning or why she was selected to receive the Stu Farber Award for Excellence in Hospice and Palliative Care, you might have a better idea now. When you walk around the Capitol with Leslie, everybody knows her, everybody says hey, and they know who she is, and they know she works for Angels. That's all of us in the room. So they listen to what she says, and she testifies on our behalf at so many hearings. And how cool would it be to have funding, a defined funding benefit for palliative care for 2.7 million people in the state? If you don't already have a palliative care program affiliated with your hospice or home health program, you need to think about getting one, because if they fund it, we will come, because you won't have to depend on philanthropy and foundation support or donated time or cobbling together something. You will actually have funding. And we also hold it in our hip pocket that if the healthcare authority doesn't come through with rulemaking, Leslie will get a bill going. She has lots of friends on the Hill, and we will keep that as our ace in the hole. So we have a 5-minute break, a stretch break. Come back quickly, because you won't want to miss the next talk either. Thanks to Leslie.
Thank you.
Okay, everybody, let's find our seats. Okay, let's get started. I have the honor and privilege of introducing our plenary speaker, Dr. Gregg VandeKieft, who currently provides inpatient palliative care consults at Providence St. Peter Hospital in Olympia and Providence Centralia Hospital. He provides telepalliative care support to 2 critical access hospitals in Eastern Washington. He previously served as a hospice medical director and cared for patients in an outpatient palliative care clinic. He's a clinical professor of family medicine at the University of Washington. He completed the University of Washington certificate program in healthcare ethics, Michigan State University's master's program in health and humanities, and Harvard Medical School's program in palliative care education and practice. He received the 2018 Hastings Center Cunniff-Dixon Physician Award in the Senior Physician category, and the 2017 Stuart Farber Award for Excellence in Hospice and Palliative Care from the Hospice State Hospice and Palliative Care Organization. So it's my honor and privilege to introduce Dr. Gregg VandeKieft.
I'm going to start off by saying how exciting it is to be together again. This is a very special group, and after not being able to meet together for the last few years, it does my heart good to see everybody together again. I'm also going to start by saying this talk is a lot different than I thought it was going to be when I accepted the invitation to do it. Not just because roughly 24 hours ago, after David Brunel's outstanding keynote, did I realize I'm the warm-up act coming in after the headliner already had a multi-encore performance. And that was, David, one of the most inspiring keynotes I've heard in a long time, so yeah. But also because about 3 weeks after I accepted this, bearing in mind that Barb's idea was to name this talk, Get Off Your Duff. She wanted everybody to go out there and promote community-based palliative care, which the need is there. We're all for community-based palliative care. There are way more people in the community who need palliative care than there are in hospice programs, than there are in hospitals. So yeah, Get Off Your Duff is needed. But then about 3 weeks later, Providence, my employer, cut a large community-based palliative care program in Southern California. And the Southern California marketplace is one of the places you would think it would be the most likely to succeed, right? So all of a sudden I'm going, how do I give a talk telling people to go out and do something in such complex financial times. We all know that health systems are struggling right now across the board. Operating losses are profound, and I'm starting to wonder if some of our health systems are not, in fact, too big to fail. So this talk is going to be a little different than what I thought it was going to be. And I'm trying to find the right balance of inspiration and motivation while keeping both feet on the ground. And when I went through my University of Washington ethics program training, the director, Al Johnson, had a sculpture. I wish I had a picture of it. It was a tricycle with a rope going up to a hot air balloon. And he said, in ethics, and I think here in program development, the idea is you want the high view, the hot air balloon up high, and a hot air balloon, not a plane. You need to travel slowly to see the landscape. And then the tricycle down below, where again, you're traveling slowly and see things at the ground level. And so trying to figure out, how do we do this? So that said, let's move on. Unlike Dr. Dog talking to Mr. Hydrant Head here, I don't have any conflicts of interest. So what are our learning objectives? I'm going to try and go through a few different models of community-based palliative care. Think about how to find collaborators for community-based palliative care. Leslie was talking about everybody's doing these patchwork sorts of things. I think about a group like the Lookout Coalition in Okanagan County, who's doing remarkable work through very innovative approaches. And so hoping that people can find ways to do that. And then find a few different resources to think about to assist if you're actually thinking about moving forward for community-based palliative care. So first, how many of you are currently providing community-based palliative care? Show of hands. That's a larger number than I was expecting. That's encouraging. Thank you. And I hope later in the session, some of you will come to the mics and talk to us a little bit about your experience and how you've made it work. How many of you hope to provide community-based palliative care in the near future? Okay, good number as well. Hope that's not my phone. And then finally, how many of you hope to provide palliative care in the long run? You know you can't in the near future, but you should in the long run. Okay, a small number as well. Good. Well, you think about the evolution of palliative care in the United States. It really started out in the 1970s, more so in the 80s with the advent of the Medicare hospice benefit. To really get palliative care in the U.S., you had to be in the final 6 months of life. And then in the 90s, you saw the transition really took off in the early 2000s to acute care settings, hospital-based palliative care. Both of those are really a lot easier economic cases to make. For hospice, you've got the Medicare benefit, Medicaid benefit, most insurances provide it. Hospital-based palliative care, the cost-benefit analysis is far easier to make because the hospital's investing in the palliative care team, the hospital's recouping the financial benefits, the cost avoidance from the palliative care team, and with proper data analytics, you can really demonstrate that most hospital palliative care teams are easily covering their own costs and then some. Community-based palliative care is a lot trickier because who pays for the staffing? Mostly it's going to be the agency providing it, whether it's a hospital, a hospice, a home health agency, whatever. But who gets the financial benefit? First and foremost, the insurance companies, maybe the hospitals. And so there's not a good way to match up the expenditures and the benefits to create a sustainable program. It's a much trickier business proposition. So what are some of the types of community-based palliative care? In Olympia, we have a freestanding clinic. It's pretty cool. I think we provide a great service, but to get in, you've got to be mobile enough to get out of the house, get into the car, get out of the car, get into the clinic, sit in the waiting room, yada, yada, yada. So, you know, clinics they're good. We serve a lot of patients and serve them well, but it's not for everybody. Some of the clinics are embedded in specialty centers. I'm seeing an increasing number of cancer centers in particular will have like a nurse practitioner that gets certified in palliative care, and so it's integrated. And that's actually a pretty good model if you can have it internal. Home health based, hospice based. Hospice is a little trickier because of the regulatory environment. To create a program out of a hospice agency, you have to make sure that you're not in any way stepping out of the conditions of participation with the hospice regs. And in California, they actually passed some laws to help facilitate that. California is really the front runner in community-based palliative care right now. Skilled nursing facilities, long-term care, assisted living, adult family home. You can bring people in to do palliative care there. Most of them are probably too small to have their own. I have seen some larger long-term care and skilled nursing facilities who have a few folks on staff who are certified and can do some palliative care benefits. I know some people who tried doing telehealth into nursing facilities. It works for some clients or some patients, but you've got people who are hard of hearing. It's a really tricky proposition, doesn't work for everybody. And then telehealth in general, I think of Resolution Care out of Northern California, really the front runner in doing home-based palliative care, community-based palliative care via telehealth. Remarkable model. They recently got bought by VandeKieft, a venture capital company, and are expanding into the Northwest, so don't be surprised if you hear about VandeKieft doing community-based telepalliative care. And I know they're working to try and get contracts with some of the payers in the Pacific Northwest to expand their footprint and be able to increase the access. And as Pat said yesterday during the Rural Palliative Care Initiative, I believe deeply this is an access issue, which makes it an equity issue. If you live in a rural setting, you should not have to settle for second-rate care. You should still be able to get top-notch care. And telehealth is one way you can help bridge that gap. When you can't get the specialists there in person, you can at least get the specialists there virtually to help serve those needs. Who sponsors community-based palliative care programs? That's all over the map. Some of them come out of hospitals, home health programs, hospices, medical groups. In Southern California, there's a really innovative group that is succeeding. Interestingly enough, also in affiliation with Providence, but in a different environment. The one that they cut was in Orange County. They've got a very successful program in the San Fernando Valley, and they've contracted with a large medical group there and also an accountable care organization, which is why it's been successful. Independent programs, you get the volunteer coalitions like the Lookout Coalition I mentioned earlier. PACE programs, Program for All-Inclusive Care for the Elderly. If you're not familiar with PACE, learn more about it. It's truly, I think, one of the more innovative models out there, and I'd love to see the PACE model expanded over time. And then integrated payer-provider systems. I think about groups like Kaiser. They are both a payer and the provider of clinical services, and it makes sense for them to say we ought to provide community-based palliative care because in the long run it's going to really reduce the amount of services that we have to provide, and it's not in a bad way, but unnecessary services or preventable services, and in the long run we'll financially benefit. So I expect to see the integrated programs really promoting community-based palliative care increasingly over time. What services can community-based palliative care offer? Well, you start with symptom management. And I sometimes see palliative care programs that really all they do is goals of care. And, in 2005, 2006, that may have been appropriate. We didn't have the full range of services, the staffing available. So what do palliative care programs uniquely bring? The communication skills to articulate treatment goals and to try and arrange for goal-aligned care. That's really important. But if you're going to try and keep people out of the emergency room, if you're going to try and keep people from being hospitalized, you need to have the skills to manage symptoms as well. And hospice nurses know this deeply. When you've got a patient who's in a symptom crisis, you've got to be able to address it. And I think the same with community-based palliative care. You need to have the means to deal with acute symptom issues when they arise and not put it off until Monday, because otherwise they're going to call 911 and be in the emergency department. Prognostication, communication, those communication skills expertise that we offer, and I really see that as something community-based palliative care can provide uniquely. The patient-centered goals we've talked about, and then also just really planning for the future in serious illness. What we do when you hear about all the information, you process what the doctors have told you. When you think about the future, what are you hoping for? And then trying to find out if we can align the care so that we can best achieve the patient's goals. Pat Justice brought this to my attention, and this is from Pippa Hawley at the University of British Columbia. You've all seen that one model of the kind of two triangles with the wedge at the end, symptom management on the one end, palliative care on the other, hospice and bereavement. I like this because it goes further. So when a person's sick, on the left side, when you come in with newly diagnosed cancer, you're going to want the full range of treatments most likely if you have the possibility for a cure or a remission, at least prolonged life. So chemotherapy, radiation therapy, et cetera. And then you get the overlap where you're also doing, while you're doing hopefully curative treatments, symptom management treatments like transfusions, anti-nausea drugs, antibiotics, and so on. But then later on, you go one of two ways, and this is what I like about this model is that's unique, is it includes survivorship. Our palliative care clinic, when we first opened it, some of the first patients we got were in remission from head and neck cancer, but they were living with profound symptoms: depression, nausea, vomiting, inability to eat, radiation stomatitis that created severe pain, social isolation. And so spending time with the survivors at times is just as important as end-of-life care, which is why I like this model, is that it highlights palliative care is not just for end-of-life care, it's also for long-term survivorship when palliative care needs exist. And so that's really what I would hope our community-based programs could accomplish. So what are some of the traits of the successful programs? And this is a little busier slide than I like, but we'll get there. First off, value-based contracting. The traditional fee-for-service model is not going to sustain community-based palliative care. The expenses of running an effective palliative care program will never be covered by the potential billing you can do. So you've got to find ways to cover the gap. Strong provider presence. So I've called around and talked to a number of people running successful community-based palliative care programs, and that theme came up again and again, that as much as and that's a program that's nurse and social work led can do in many areas. For the complex symptom management, keeping people out of the emergency department, you need to have access to providers who can help write the prescriptions, cover the symptoms in real time. Otherwise, you're still going to end up with people coming back to the emergency department. Patients in some programs, what they do is they assign a level of acuity. So, okay, this person really has high complexity. They're level 1. This person's intermediate, they're level 2. This person's pretty low key, level 3. So ways that you can do it where that helps you decide the frequency of visits, and it helps you decide the potential expenses. It's going to be a way that, and it's a complex process to do, but the successful programs really like the level of acuity ranking. You need to define your scope of services clearly. We were talking at our table yesterday about not making promises you can't deliver, or making promises that others prevent you from delivering. And so you really want to define your scope of practices so that both the people you serve and the referring providers know what they're getting. You don't want to necessarily be the chronic pain clinic in town, and a lot of palliative care programs, they start to fall into that if they don't set clear boundaries and really define their scope of services. And then there's a way to communicate that cleanly as well, because sometimes a palliative care clinic will say, well, that's a chronic pain clinic patient, we're not going to accept them. And the referring provider's like, well, fine, I'm not going to refer to you again. I went through that one time with a rad-onc doc who had referred somebody to us who had to go off their immunologics for their, I believe it was rheumatoid arthritis, because the therapies that they were getting for their cancer conflicted. And so after they finished radiation, she wanted our chronic pain clinic to take over. I said, I think they're DMARDs, the disease-modifying anti-rheumatic drugs. Let's first have them see the rheumatologist and see if they can take care of things. And then if you still need things, talk to me. But it was a doctor-to-doctor phone call, and at the end, she thanked me, and we had a good rapport. So you don't want to just say, we don't do that, and shut the door, because you'll lose future referrals. So to be an effective program often requires picking up the phone and talking person to person. Maybe provider to provider, maybe the nurse manager. You can define different ways. Because of the nature of the physician culture where I practice, I tended to make the calls myself so that it was a provider to provider call, because that way they didn't get snippy with me or with our program. And then strong relationships with the people in the community who send the referrals. Primary care first and foremost, but you think about relative subspecialties. Oncology in particular, but cardiology increasingly, pulmonary. And so going out and meeting with them. When we opened our clinic, I went to dozens of practices in the community to sit down and talk with people, to talk about what's realistic. And, at first there weren't a lot of referrals, but over time word spreads. It only takes one or two where somebody says, oh man, I referred them to palliative care, and what a difference did that make. And similarly, probably our one really effective community-based palliative care, home-based palliative care program is with Kaiser, and it's a small program, but when the nurse, the doc, the social worker from that program go out to the house, it makes a dramatic difference, and word starts to spread. 24-hour call center. This is a tough one. A lot of places who do this, the way they do it is to collaborate with hospice agencies, since all the hospice agencies have 24-hour coverage. And many of the programs, you don't need to necessarily deal with things at 2 a.m., but you need somebody to take the 2 a.m. phone call and decide, I need to triage this. Do I need to call a provider now because we're in a crisis, and if we don't deal with it now, they are going to end up in the ER by 8 a.m.? Or is it something like, we can ride this? Hospice call centers, hospice triage nurses do this all the time and understand it well enough that many successful programs find that that's a really good collaboration to establish, and that way you don't have to recreate the program from the ground up. And it's going to depend on your location as well. Not every place has a hospice agency that they can work with in that way. So then how do you decide what do you do in the after hours to meet needs that arise and aren't respectful of Monday through Friday, 8 to 5 sort of boundaries? So initiating it, so we got the control room up top and the launch down at the bottom. Before you launch, a lot of work needs to go into this. You really need to do the work to decide. So some of the key questions: what problem are we trying to solve? That's one of my favorite questions when we're doing this type of work is, okay, we're talking about this program, but what problems are we trying to solve? Because that's going to kind of help define, okay, well, that determines what the need is going to be, what sort of model we should think about. What patient population do we hope to serve? Sometimes it's going to be the cancer patients. Sometimes it's going to be the cardiovascular patient. Sometimes the geriatric patient. And maybe it's more general, but really thinking who are the quote-unquote low-hanging fruit to start with, and where are we going to have the greatest impact in our community by serving. Also, recognizing your own limits. I'm a big fan of the phrase under-promise and over-deliver. You see that at the bottom there. If you try and be all things to all people at once, you're going to fail. But if you start small, have a soft launch, and really look at, so maybe I shouldn't have used the space shuttle, maybe I should have used one of those backyard model rockets. But you start small and do a good job. Just show up and do a good job, and then the growth will often take care of itself. What resources do we have to support a program? That's a biggie. If you're hospital-based, the amount of resources are going to be different than if you're home health-based. And when time gets tough, how are you going to sustain those resources? Who's going to staff the program? Do you already have the staff in place? Are you going to need to hire up? How many people do we need? And who's going to be our champions? This is huge because you've got to have an administrative or executive level person who's championing the program if you're really going to go anywhere, and hopefully somebody who isn't going to leave within the next year. In this era of a high rate of turnover, I'm seeing programs that got off to great starts, and 2-3 years later, the entire C-suite's turned over, and all of a sudden the support has evaporated. So really look at who are the people that are championing the program. How much can I count on them to continue to be champions? How much institutional is their support beyond the individual champion? You may have to start out with philanthropy. Many programs will turn to, whether it be Robert Wood Johnson, Cambia, different organizations, maybe something locally. And I'm not the philanthropy person, so I'll trust Pat and others to maybe speak up about other ways to think about how do you find the resources? Because many programs, the operational budget in the first couple of years isn't going to cut it. Or is the organization starting it going to say, we can take 2-3 years of operating loss as long as we're minimally staffed, counting on getting up to being a self-sustaining program. And when our clinic founded, that was the thing. The chief strategy officer said, I know the first 2-3 years we're going to lose money, but as we move towards value-based contracting, we can't wait until then or we're already behind the game. Let's found the clinic now, start seeing patients, recognize that we have to support it through the first few years, and then hopefully we'll catch up. And then we got our hospital foundation to name the clinic. It's a Fund a Need program for that year, and we got over $250,000 of philanthropic funding to launch the clinic. And so creative ways to get started, recognizing that the sustainable model may take a few years to develop. Truthfully, I don't know that we're sustainable yet because value-based contracting hasn't gone as fast as we would have hoped. And I'd have this little voice in the back of my head saying, are we at risk? Because there's an environment right now where anybody that's not generating revenue is at risk. A lot of really valuable programs are being shut down because they cost more than they're generating revenue. And health systems are in sort of panic mode, so programs like that are at risk, and that's part of where I felt like today, got to have the feet on the ground, the tricycle mode of being realistic despite the higher aspirations of where I want to see things go and where I hope things will go. You have to have case narratives, so collect stories, both stories of successes. We intervened. I was talking with some of the folks from Dayton yesterday about people who'd been in the ER time after time after time after time. Their program got up and running, and it's been, I think, 3 years or so since the patient's been? 4 years since he's been in the ER. Your admin people are going to love stories like that, because that's where you realize that it may not be data in the same way, but it's a narrative that demonstrates value. It demonstrates a return on investment. Our ER is now not seeing this person all the time because we've invested in giving them care, and it's better care. It's better for the person. One of the things I learned too is don't start with the economic case. Start with it's the right care. A brief anecdote here. When we were trying to found our inpatient palliative care program, our mission director was one of the people that was involved in founding it. So we had to go before the big board. She immediately started with the business case, and our chief financial officer stopped her. Connie, you know I'm interested in the finances, but the first question I want to have answered, is this the best care for our patients? If you got a CFO like that, you're in great shape. Unfortunately, he moved to Hawaii, but that's a different story. And then really explore innovative partnerships. You may be able to have, like in California, the Medicare Advantage programs are one of the big things. Now, California passed some legislation. They had Tori Fields, who did an amazing amount of work to help get their palliative care benefit. A lot of our work that Leslie talked about, we're trying to learn from that lesson, and that's the promotion. And if we get that passed, that's going to really change the playing field tremendously in the state of Washington. And then you can partner with ways where, if you're saving Medicare Advantage programs or an accountable care organization a bunch of money, they're going to say this is a really good investment. And it may be a large medical group if you're in a more urban setting, or maybe a large medical group that spreads out in a rural area. I don't know what Confluence Health is doing on, in this region, but they have a large enough footprint. You have the possibility of a group like that saying, even in a rural setting, we should invest in this. And then negotiations and budgeting are crucial. If I had to do negotiating and budgeting, we would go bankrupt yesterday. And so you need to have people who have those skills. And so finding the right people to help do all those things. So I reached out to the director of one of the more successful programs and just said, what would you say? I told him about the talk I'm about to give and the context I'm giving it in. And what would you say? And so he said, define your success measurements from the outset. How do we know we have succeeded? And don't kind of wait and see, but really work on that in advance to say, what problem is it we're trying to solve, and how do we know that we've accomplished that? He said, know your costs. Be realistic about, okay, if we have windshield time for people going out to the house, administrative time, staff time for all the different disciplines involved, really have people who can put that down to a concrete, realistic budget, and don't lowball the budget or you're going to go over on costs. You really know your costs and be realistic. Plan for growth. If you succeed, you're going to have to grow. Okay, 6, 12, 18 months down the road, if we have to hire new staff to really handle the increased volume of referrals, are we ready to do that? What are the means we're going to do that? Think about education. Educating the community, so some community outreach, educating referring providers. How much time are you going to need to invest, and how much is that going to cost to send people out to the primary care clinics? Usually you want to bring donuts or pizza or something so they listen. And the administrators and the other people who have to who control the purse strings to make sure they know what's going on. And a thing I've learned over the years too is education needs to be ongoing because of turnover. The person you educated today may be in a different position in 3 years, and the person who took their job, you may need to re-educate them. So be ready for kind of looping back, making it an ongoing process, because otherwise you regress to the mean. Leverage support assets from pre-existing infrastructure. So in this case, they really looked at, there was an accountable care organization and a very large physician group that felt like we have problems with our people cycling through the ER in ways that we think are not good for the patients and certainly aren't good for the health system or its financing. How can we address this problem? And so they took it was out of a blended palliative care, home health, and hospice program, and they created their community-based palliative care program to address it. They determined up front what were going to be our success measures, and they were able to demonstrate after a fairly short period of time a dramatic reduction in emergency department visits and admissions, and that really resonated with the Accountable Care Organization, the physician group who had established the program. And then finally, be prepared to course correct based on feedback and data. You know, as things come in, you're going to find surprises. Oh boy, we're having to spend way more on social work than we expected because our patients' needs in social work are just so intense. Okay, we may need to shift some of our funding. Be ready for that. And then, you know, take the data in and, you know, don't interpret it the way you want it to be. Interpret it the way it is, and then be ready to respond accordingly. So sample care model, this just came from that same program, and this isn't, I'm not calling this best practice, I'm just saying this is one way it could work. So they have an initial assessment by RN, and they review the eligibility guidelines first off, and they have a set of eligibility guidelines. Does this person qualify for our service or not? If yes, and similar to hospice nurses evaluating whether they qualify or not, decide whether to admit or not. And then if not, maybe consider a referral to home health or hospice instead, again with a high level of communication with the referring provider if they're going to do something different than what they asked for. And then the initial assessment by a provider. That's usually a nurse practitioner in the community setting. Some programs prefer to use physicians. I'd say it's got to be program specific. What serves your community needs the best? And then do the initial symptom assessment. What's their nausea and vomiting, their pain score, or whatever else, bed sores and so on, pressure ulcers or so on. And then establish a general management plan. You know, how frequently are going to see this person again? They use the acuity setting. Level 1, they're going to set up the visits more frequently. Level 2, less frequently. Level 3, less frequently still. And then figure out who needs to go out and how often. After hours call, what they've done is they've partnered with a hospice agency. So they have triage nurses who gets the after hours call, determines, do I need to call the provider now? And they have provider coverage available by pager and, well, maybe today's cell phone. I'm still talk pager because I'm old. And, you know, you figure out who needs to deal with it and when, and get the follow-up set. And then social work gets involved at the front end. And then as things go on, how often more does social work need to be involved? Their particular program, they have spiritual care by referral. That is, not every patient gets seen by a chaplain. You know, it's not a hospice program. It is palliative care. I personally would like at least every case to be reviewed by spiritual care. Their program, I don't know if they do that or not, they do the spiritual care by referrals. That's just one model to see how it could work. What are some sample measures? So you could look at, okay, what is the impact on emergency department visits? What is the impact on hospitalizations? And think about average length of stay. One of the things our clinic has seen that when our patients do get hospitalized, their hospitalizations tend to be shorter than the comparable patients because they've already been addressing palliative care issues before they came in. They're more likely to be seen by the inpatient palliative care team. And so you can even say, look, key thing is not average length of stay. The key thing is to say bed days saved. Because with throughput being in a crisis in many hospitals, if they know they can open that bed up in one of the borders in the ER, and I can't tell you how many palliative care consults I do in the hallway in the ER now, if you can change that environment, there's value. Value is more than just the finances. And so if you can demonstrate value in that way, it's going to make a difference. But then in this day and age, total cost of care is probably going to be the most important thing. Think about advanced directive and pulsed completion. You know, we've seen in some of these programs a marked increase in the amount of advanced directive and pulsed completion compared to the population at large. Patient experience. How is it for the patient and their families? And this is harder to read, but I would also love to monitor caregiver experience. Because think about the caregivers and the moral distress they have when they see all this unmet need. And if they can see a program that is really addressing unmet need, it's going to reduce their distress, their sense of burnout, all of those things. And then hospice referrals. Do we have a higher rate of hospice referrals? Not every palliative care patient should go to hospice, but you would expect to probably see a higher proportion than the population at large with similar diagnoses. And I didn't put it on here, but length of stay in hospice. If they get an earlier referral, that should improve quality of life, should improve patient and family experience, caregiver experience, and be beneficial to the system overall. So what do you do after the program goes live? Track and report data. Who determines the fate of the program? That's really crucial. Is what data should we collect? Well, the data that matters to the people who control the purse strings. I hate to sound too mercenary there, but if you're going to survive, you've got to satisfy the people who make the decision, do we maintain the program or do we cut it because of hard financial times? So find out what those folks want to know, track that data, and make sure that you're meeting their needs. And think about what do you need to know internally for staffing. So if you're going to collect data, do we need more nursing visits? Do we need more provider coverage? What are the needs there? And then use the data to help generate it. Collect stories. I talked about that earlier. It makes such a difference where the program is helpful. But one thing I didn't mention earlier is where was the program, where were missed opportunities? As we were developing our tele-palliative care program in Stevens County, one of the things that was really valuable is some stories of patients who, if tele-palliative care had served those patients, it would have made a very positive difference. They weren't there. They got transferred back. Care didn't go well. And so, and not to do that in a way that seems critical or judgmental of it, but that just says the usual practice is like this. Here's how it could have been. That would have been a better experience for all involved. And then education, again, patients and families, referring providers, clinical staff. Many clinics you could have, it doesn't need to be the provider necessarily that has it. They could have a trigger system or a clinical indicator system where a nurse in the clinic says, hey, doc, they actually meet the criteria for palliative care referral. I think we might want to do that. And so there are a lot of different ways you can do that through education and using tools and resources. Community education. One of the things that was really cool in Stevens County is when patients started to come in and say, I know somebody that had that palliative care consult. I would like that. And we've had patients in our clinic. One of my favorite stories was a woman whose daughter had read Being Mortal and goes, this is what mom needs. So she Googled palliative care Olympia, found my name. And next thing, she's in our clinic. And older woman with advanced COPD who I referred to hospice, and she came back because she outlived hospice because things had improved so much. And they had this great quote in the rural palliative care tape where she goes, I'll tell you what, if it wasn't for palliative care, I wouldn't be here today. I thought, that's not how most people think of palliative care, that we prolonged her life. We just thought we were improving quality of life, but she truly lived longer. And then a wellness plan. Think about your staff and their needs. I think this is essential. To be proactive. To me, burnout is an organizational issue first and foremost. Many of you have heard the quote, you can teach the canary in the coal mine how to meditate, but the bird's still going to die. You got to change the toxic environment. And if wellness is all about the individual, then burnout is a failure of them. And most of the time, burnout is a failure of the organization to create a sustainable work environment. So be proactive. Be mindful that if we're going to have staff who can meet the needs of our patients, who are doing physically and emotionally demanding work, yeah, you're angels, but angels don't last forever if they're under in unremitting distress. So be proactive about wellness plan for retention and recruiting, and it's in your best interest, because if you're losing staff, that's expensive. It undermines quality. It's going to put your program at risk. So have a wellness plan as a upfront part of it. This may be the most important slide if you're looking into it, and if you are seriously looking into it, you probably already know about it. The first one is from the California Healthcare Foundation, and that particular URL, they've got a bunch of resources on community-based palliative care. Now, some of their resources are really targeting public hospitals. They did a really hard drive on getting public hospitals in places like Oakland, California, with very underserved populations to do it. But their community-based palliative care resources are excellent. So if you're looking into building a program, I highly recommend that. The Center to Advance Palliative Care has both a website. There's a monograph, but that's behind a firewall. So if you don't have a membership, you may not be able to access it, or you can email somebody like me and I'll send you a PDF. But again, very valuable resources for trying to build the programs and what you're thinking about. And then just an article at the end that really did a nice systematic analysis of what are the impacts. That's the end of the prepared talk. We've got about 20 to 25 minutes, and I intentionally left the time because I want to have people come to the mic and ask questions, or come to the mic and tell stories. Those of you who've had programs that have been working well, or if you've had programs that have struggled, I think having an exchange here would be really valuable. So hopefully somebody will come up, because otherwise I'm going to call on the Dayton team and they're going to be mad at me. Yes, and could you come to the mic, since there are people who are on the video?
Actually, I am from the Dayton team. So, Teresa Iyer, her voice is a little under the weather. So
Okay.
I'm Dawn Miker, I'm a nurse practitioner, and I was blessed about 15 months ago to be able to be the population health provider champion for Columbia County Health Systems. We're in Dayton, just down by Walla Walla, down in the southeast corner. We're blessed to have 2 rural health clinics. About 4 years ago, our COO, Stephanie Carpenter, RN, and Teresa Iyer, RN, started our palliative care program with just those 2 people because we saw the needs. I want to say that you are dead on all your points. I've been 15 months now being the provider champion. And these things, especially what these girls do, is amazing. We are blessed with a lot of patients down there that are hugely high need, and they are just really, really tough patients. So being able for me to be the provider champion for our CCM, our palliative care, and also a disease management program for COPD and CHF, that came about from a HRSA grant. So they were able to have me take over as the provider champion. That has really helped our clinic providers, because I can take some of the things off of their plate with all the phone calls that being on speed dial for our 2 RNs. So that has been huge. So really having a provider champion in your corner helps a lot. I'm able to, just really help them all the time. Through our HRSA grant, we were able to work on this disease management program. We found out that the things we were trying to do for billing and reimbursement, talking with our coders, talking with our billing, we were getting reimbursed. Our problem with our electronic health record is we can't say, okay, EHR, show me all the PC home visits. So our palliative care home visits, we should be able to just pull a report. No. So I have to literally manually pull those. I send them to our billers, and they're able to say, okay, in August you were reimbursed $357. So that is a real problem. We're going to be switching over in 15 months to a different EHR. I think that's going to help a lot on our data. Through our HRSA grant, we were able to get a data analytics, and that's going to really, really help. So we'll be able to report that back to the state, and I think that's going to help immensely. So dead on all these things. We are also putting our PIPH, which is our disease management program, and our palliative care patients in our CCM, because there is a lot that these girls do on the phone. So all of that stuff that does not happen in the home, we're keeping track of that, and if we get those 20 minutes, then we can drop a bill for CCM. So we've kind of been able to blend all these programs together. Supporting your team is huge. The things that my girls, the 2 RNs go through is amazing. We've been able to take on some really heavy psychiatric patients, because those were the ones that were, life-limiting for them and in our emergency rooms, and being a big strain on our rural health clinic providers. So we've taken on some of those, but what it takes out of their quality of life and their length of life, I see. So really supporting those and being able for us to come here under a scholarship and be together and really do some team building has been huge. So thank you on all those.
Don't step down yet. How many patients do you have on service right now?
We're usually running about 55 to 63. As of today, I think there's 58.
That's an impressive number. Because it says, how many staff do you have?
We have 2 RNs. We have me as a part-time, and we're able to have one of our PCRs, our front desk people in the clinics, a little part-time. And we were lucky enough to get, through our HRSA grant, we really needed a social worker. We had 2 false starts getting one. So we finally decided to grab a community health worker. She's a wonderful guardian through state, so she has a lot of those skills that we need. So we've been able to bring her on. I think that's going to take a huge stress off Teresa and Jennifer.
Yeah, and that last point you made, I hadn't thought to include this in the talk, but hiring for fit is so crucial. One of the biggest mistakes programs can make is the any warm body situation. Plugging in a social worker and finding out this was not the right fit. And I love that you found a community health worker because, again, being very creative in finding who's the right person for the job as opposed to what's the right degree for the job. Not to diss social workers, I'm a big fan, 80, but you really need to make sure you hire the right people. Team chemistry is so essential because otherwise, having internal conflict is going to exacerbate burnout. The final thing I'll add is Dayton was in cohort 1 of the Rural Palliative Care Initiative, and Stephanie Carpenter, who you mentioned, was huge in that. And having an advocate like that, she was CNO, now she's COO, having a champion there who gets it, who supports it, and really looks at the big picture. She's both on the tricycle and in the hot air balloon, and that makes a big difference. So finding a champion like that. Thank you so much for sharing.
Absolutely. Thank you.
Chris.
Greg, thank you for your expertise. Thanks for being here. My question really looks at the economic realities that you highlighted, some of which you and I had a conversation outside as well. Recognizing, I think the VNCA program you're talking about has probably practitioners and schedulers. From that, you might have a totally other end of the spectrum. You might have a fully staffed team, and we tend to be on that end of it. As we look at the question of whether people are going to be able to do it or not, can you help us start with building blocks? What are the essentials of what you have to have for a palliative care program? What would be the next thing that you would add to that? Really just the economic realities, I think, are forcing everyone to question and wonder and to support. The one who runs our program, Marcia, is unbelievably focused on the patient and also unbelievably focused on trying to make sure it's economically sustainable. So those dynamics are really I'm worried about her burning out, and she's just an amazing person, so would love to have your thoughts on that.
Before I share my thoughts, this is a bit of a cheap trick. Tell me what you think the essential building blocks are.
I knew that was coming. I tried to get away. David, you're up. David's up. Well, you supported the VNCA. I mean, you talked about the VNCA model as if it could be viable, and it is, and it's a good place to start. The practitioner, probably a nurse practitioner, I would guess, being scheduled to talk to the patient and have those dialogues. I think that's critical. We've really leaned into the hands-on. We have nurses, both RN and LPN. We have social worker. Jenny's here. We have chaplain available for that patient. We have the nurse practitioners, obviously, who do both hospice and then palliative care kind of geographically. So,
okay. Thank you. Thanks for letting me exploit you like that. So building blocks, I think on the front end, people who have the business savvy to know how to run a program. It's an odd place for me as a clinician to suggest you start, but my clinical services will not be available if I build a non-sustainable model. So having people who can assess, and I need to step back even a step further. If I think about building blocks, the first is a community needs assessment. And Kelly did a great job of that in Stevens County together with Pat through the Rural Palliative Care Initiative, really assaying from provider groups, hospitalists, emergency persons, primary care, other people out in the community. What are the missing needs? Again, what problem is it we're trying to solve? What patient population are we trying to serve? So doing that work up front and having the people who can do that work. And that's where if you're in a rural setting, reaching out to Pat and others for expertise. because many communities, you're not going to have the folks who can do that work in your own, so reaching out to partners. And then even reaching out to folks like Dayton and say, how did you go about getting that HRSA grant? So figuring things like that out up front, the business modeling first. From a clinical standpoint, I would say at the very least you're going to need, well, before I get to that, then you're going to need to have people who's going to field the calls, when a referral comes in, or take it out of the electronic record, who's going to transmit the messaging. So you need the proper administrative support staff. And how much administrative support staff is that going to be on the front end? It may be just a half-time administrative assistant. You may need to have somebody full-time who's doing a lot more, but kind of working on that. And then from the clinical side, at the very least, a nurse, a provider, I think a social worker, and access to chaplains, if possible, a pharmacist. Yeah, at the very least, having a community pharmacist who you can reach out to say, hey, I've got this complex need, I might need some compounding, if you're going to really provide the services in the community. And then the resources to figure out, again, how do we deal with the after-hours issues when they come up? Do we have to partner with hospice? Do we have it go through the inpatient hospitalist team since they're going to have 24/7 coverage? Somehow or other, if stuff comes up at 2 on a Saturday morning, you don't want them in the emergency department if it can be avoided. And can that all be managed telephonically, or do we have the resources to send somebody out to the home? That's where partnering with hospice is valuable, because that's stuff they've been dealing with forever. So I think that hits it. And I know he tapped you, David. Any other thoughts?
I have one. What about a billing expert?
Oh.
Billers are worth their weight in gold.
Yeah.
You need somebody who can maximize the billing for your services whenever possible. And I'll get out of the way for David, but I do have a couple other questions.
That's a good call, Barb. Thank you.
Just two things, because you've already danced around this, but I think it's practical. One was identify a problem you can solve for somebody else. You know where it exists, but if you can say, by introducing palliative care into this population, we can take that part of that off your hands. We can help you solve that problem. Everybody loves that. And then once you move from there, we would put triggers in place for certain clinics and find, let's just say, our oncology people were overwhelmed, and we had patients who had recurrent leukemia, and the outcomes weren't so good. That was an automatic trigger for a palliative care consult. So that's just a couple more practical things.
Yeah, and it's been interesting to me, David, as you talk about triggers. A few years back, triggers was almost a dirty word, and so we called them clinical indicators instead. I've found in the last year or two, triggers are now welcome. I don't know how much it's because we're graduating people who trained with palliative care, and so they get it in a different way than the older generation. I don't know how much it's because things have changed and the cardiologists are like, I need help. I'm overwhelmed right now. But what I've found, at least in Olympia, that there's a receptiveness to triggers. I don't have to use the euphemism clinical indicators any longer, although I still usually do. But people welcome that because it helps. The key thing is show up and make their life better, and they're going to be more amenable to your services. The biggest critic of our program when we started, I don't need palliative care. I take care of people in the ICU that are dying every day. This is a stupid idea. By the time he retired, he would see me in the ICU and hold this patient list out and go, can you see them all? And I still remember some of the first cases where, he had done everything he could and finally threw his hands up, and I'll see if that stupid palliative care doc can make a difference. And I did. Because I'm coming from a different model. I mean, this guy's brilliant. If I was ever in the ICU, I'd want him taking care of me if I was hoping to survive. But if I wasn't going to survive, he wasn't necessarily who I wanted taking care of me, and so I could make a difference. So just show up, do a good job, make their life better, and the demand for services will grow.
So I want to ask, one of the measures of success that you had on your slide was decreased hospital readmission rates. And I wanted to ask the group, any programs that are providing palliative care, are you getting any funding, whether you're hospital-based or not, from hospitals because you're decreasing 30-day readmission rates? And that has an impact on hospitals' revenue and their COP scores. Is anybody getting any funding, or have you approached? But do you think it's possible? It's conceivable? Yeah, I would make an appointment and go ask for money, go ask for funding, and not by per patient, but like $10,000 or $50,000, you know, if you can calculate what you have saved them and the value you're bringing, I mean, I think hospitals could be a source of funding.
So we were approached by a regional chief medical officer because one of the hospitals had been dinged for their cardiovascular CHF 30-day readmission rate. And they wanted to see about having us do telehealth support to all of their CHF discharges. Because of the financial chaos that's going on, that it got lost in, you know, it's kind of that Maslow's hierarchy of needs thing. We were too high up the pyramid, but it's a possibility. So again, this is, what problem are we trying to solve? What patient population can we have the greatest impact on? And so if they're having problems with their CHF 30-day readmission rates, that could be a really ripe opportunity to say, we may be able to help here.
Yeah. The other question I wanted to ask the group, and I know it's just in Clark County now, but who here serves Clark County? Communities back here somewhere, right? So VBID is only in Clark County this year, and next year there will be expansion. And what VBID is, the patients who are on a Medicare Advantage program will stay on the MA plan, and the MA plan will pay for hospice, so the patients won't revert to traditional Medicare. But those MA plans are required to cover palliative care. And right now, it's not defined how much that is. It could be 30 days or 90 days, but it's an opportunity for the future for funding if you contract with MA plans, and you will want to when VBID comes to your county.
Can you tell us what VBID stands for?
Value-Based Insurance Design, and it's a CMS partnership program with Medicare Advantage plans. The goal is to save money in the long run. So now when you have a patient who's on an MA plan, they revert to traditional Medicare when it's time to go on hospice. In Clark County, if they have Regents, they stay on their MA plan, and Regents pays for hospice. And right now, it's the same as the Medicare rates. We don't think it'll always stay that way in the future, and you don't have to have prior authorization. We also don't think that'll stay the same in the future, but it is coming. It is a train that is coming. It's happening in like 20 states around the country and only in Clark County now, but it is coming. But the good thing is they do require those MA plans to cover palliative care. So you can get in on the palliative care bandwagon, and those patients do tend to go on hospice earlier and have longer lengths of stay if they're going to go on hospice. You made the point, Gregg, that they don't always go on hospice, and that's fine. You can't think of palliative care as just pre-hospice, because it's not. But also your patients who graduate from hospice could go on the palliative care program, and what a great way to keep track of them. So anyway, those were the questions I wanted to ask.
Dr. Goldberg.
First of all, thanks, Gregg. I always learn when I listen to you, so thank you for the presentation today. I think we are all being asked to do more with less. We are confronted daily with new cuts, positions rift. So I guess this is a personal question, which is, how do you hold on to hope amidst the reality that we all live with?
Oh boy. Yes, thank you. Well, I'll start by saying I had an hour-long conversation with Hope out on a bench by the lake. Is that the Hope you mean? Oh, no. Is she here? I'm a Pollyanna by nature. I'm the type of guy who looks at the glass as 10% full rather than 90% empty. I've also been one who has always felt that stuff happens, but usually if you leave yourself open to the universe and how things unfold, opportunities emerge. I was in the play Sound of Music in college, and I always loved the line, when God closes a door, he opens a window. And so, and for those of you who don't know, Adi and I are right now going through some transitions because of this situation, and how do we find future opportunities that will serve us in the best way possible. I also recognize there's a lot of that going around, and right now in Providence, our cancer pain center at the Portland Cancer Program was shut down with no preamble, just, you cost too much, you don't generate enough revenue. Dozens and dozens of people have been reduction in force. And so having empathy, compassion, understanding that there's a lot of hurt, a lot of turmoil, a lot of a lot of people going through times in their life where they're having to asking these questions. So how to balance looking ahead, trying to develop programs like this, to promote programs like this in an environment where the healthcare systems, including those that espouse lovely values, don't seem like human interest or caring for, or the human caring seems to be lacking. I would often revert back to the starfish story. I may not be able to change the big picture, but you all know the story probably. You know, the little boy's walking along throwing starfish into the water at low tide, and the old man says, "You'll never be able to save all these starfish." And he picks one up and throws it in the water. I saved that one. Of course, one of my nurses, when I told him that story, goes, "Why doesn't he just wait until high tide?" Joe, you're missing the point. But there are a lot of days that I get done with my work day and I say, one starfish at a time, baby. That felt good. It made a big difference. And that's where the clinical work is still so gratifying, because when I end a day of clinical work, and I still am clinical, and unfortunately I have Thanksgiving and New Year's Eve and New Year's this day, so I couldn't bid on the Seahawks tickets. But at the end of those days, recognizing this is our, so there's job, career, calling. For me, it's a calling. You know, this is what I went into medicine for, to spend a day with patients and families and making that difference. And if we can extend that from the acute care setting and into the communities, whether it be through telehealth, whether it be through going out to their homes, whether it be patients coming into the clinics, and we are meaningfully impacting the lives of the patients and families we serve, the caregivers care for them, that's how I hold on to Hope 80. And it reinforces it. Yeah. And with that, I will add one final touch, is the love of the people that I work with. I have experienced so much love here this week, and I don't use the word love lightly. So thank you for being a group that I can say that about and not feel too cheesy. So. All right. Oh, Meg has an announcement before you all talk.
Because it revolves around the next set of sessions. We're meeting in 4 breakout sessions this afternoon. The park room across the street is now divided into 2 rooms. We've got the north room, which is the one that you enter the door as you cross the street. And then the south room, which interestingly enough, we will enter through the north room all the way to the back of the park, or to the south. So we ask that those of you going to the south room get to your presentation on time, because we will close the door between the 2 rooms. Thank you.
Hey, Meg, is Michelle Micus here in person, or is she doing her presentations virtually?
Okay. Are you all here for the VSED workshop? You look like a bunch of Presbyterians all the way back. Do you want to move forward? No. I tell you.
We have about 2 minutes still. And since this is also being streamed, I'm going to be good about being on time.
Thank you for doing this. Oh, thank you. What a pleasure. Tag team. And I have to be. I just need to here.
Okay.
Just different lighting.
Uh-huh. Yes. Which side of my face?
Why do people sit at the back?
So this is the session on voluntary stopping of eating and drinking in theory and practice. My name's Marie Eaton. I'm the community champion for the Palliative Care Institute, and I'm also a member of the board of the VSED Resources Northwest, so I have some connection with this project, and I'm just thrilled today that Nancy Simmers and Hope Wechkin are here to share their deep knowledge about this particular option for dying. So we're seeing an increasing number of people who have advanced illness but do not qualify for death with dignity, trying to find other ways to alleviate a long lingering death, and voluntary stopping of eating and drinking is one of them. So our two presenters are Hope Wechkin, who has lots and lots of letters after her name. She has been the medical director of EvergreenHealth since EvergreenHealth Hospice since 2007, and she's known throughout the region for her expertise on a range of topics in end-of-life care. She was a presenter at the first national conference on voluntary stopping of eating and drinking in 2016, and chaired the first national conference on planned death at the University of Washington in 2019. That was a remarkable conference. Nancy Simmers is an RN and has been a nurse for over 40 years. She started as a birth nurse and has now moved to midwiving people who are dying. So she is a co-founder of VSED Resources Northwest. She's trained as a death doula, and she has supported many patients who have pursued voluntary stopping of eating and drinking and their families. She's a sought-after educator regarding the clinical care of people who choose this option and pursue VSED. So please welcome Nancy and Hope.
Thank you so much, Marie. Being introduced by Marie Eaton is it has been on my bucket list for a long time. Thank you so much for being here. I'm just going to make sure. Okay. So I just want to talk to you about what we're going to address today. Nancy and I are going to kind of tag team this. We're going to talk about what exactly VSED is, and we're actually going to spend more time talking about what it isn't. We're going to talk about how VSED compares in a number of arenas with medical aid in dying, some of the overarching medical considerations, and preparation for VSED. And then I'm going to turn it over to the person who actually knows what she's doing, and that's Nancy, who's been at the bedside for many of these cases, and we'll end with some information about some resources for VSED information. So who are we and why are we here? Really, we're here today mostly as emissaries. Last year, this book right here was published, and it is the first comprehensive scholarly book on voluntary stopping eating and drinking, written by, they call themselves editors, but really they were the writers of this book, some of the superstars in the hospice and palliative medicine world, including Timothy Quill, Paul Menzel, Thaddeus Pope, and Judith Schwartz. And they, in their infinite wisdom, because they've been around the block, they realized there are a lot of people who need to know this information who are not going to read this whole book, because that's actually not how, especially clinicians, especially doctors, they don't read very many books. They need things short and sweet, and so they wanted to develop clinical guidelines around VSED that would be easily accessible to clinicians of many stripes who are increasingly, as Marie said, are increasingly being asked about voluntary stopping eating and drinking. So a clinical guidelines committee was formed, and we are two of the people on the clinical guidelines committee, and we have been meeting every month for, I don't know, the last 7 months, for 2 hours at a time, hashing out clinical guidelines, and I'm delighted to say we are this close to being done. We actually have our last draft that's gone out for comments, and this will be available, I think, by the end of the year, widely available, the first national clinical guidelines on VSED. So we are here, yeah. So basically what you're going to hear today is a condensed version of those, or maybe an expanded version of those guidelines, because it's a fairly short document. So I'm going to start by actually talking about a patient who I had who was really a very formative patient. He was early. I met him probably now about 6 or 7 years ago. In the context of palliative medicine clinic. He was a 73-year-old retired architect with PSP, a variant of a Parkinson's-like syndrome. And he had been referred to palliative care clinic by his neurologist. And he was a delightful guy, highly realized person, very thoughtful, very intelligent guy, who was having a gradually worsening quality of life. And he said, what about medical aid in dying? What about the death with dignity? And the problem was, for him, as he saw it, his problem was that he had a prognosis maybe of 3 to 5 years. I mean, it was really hard to predict, but it was in the years range. He wasn't remotely eligible for medical aid in dying. So we talked for a while, and this was the first time that I actually introduced the concept of voluntary stopping eating and drinking to a person rather than have them bring the idea to me. It was pretty not talked about a lot, and it felt like honestly, it felt like a little bit of a risk to me to introduce this idea to him. But he was very grateful for the information, and we continued to meet about every 3 months for quite a while, for almost a year. And I got to know him and his wife very well. And over time, we talked about this more and more. I was really kind of flying a little bit by the seat of my pants because I had not had very much experience at that time with patients who were pursuing this. But he eventually chose the date that he was going to stop eating and drinking. And there was a lot of discussion. He had many discussions with he had 2 adult daughters, many discussions with them. And we met again 2 weeks prior to his, quote, start date, just to confirm that this is really what he wanted to do. And his wife was incredibly supportive and on board. And this was the thing that at that time felt quite unclear to me. Was at that time he was, and I had 2 roles. I was the palliative medicine physician in clinic, and on Tuesdays and Thursdays, and all the other days of the week, I was the hospice medical director. So and you can imagine the conversations between the 2 of us. And and the hospice the palliative medicine doctor said, this guy needs hospice. He needs hospice support. And the hospice medical director said, but he doesn't have a prognosis of 6 months or less. How can you possibly refer him to hospice? And the palliative medicine doctor said, well, he doesn't have a 6-month prognosis now, but he will once he starts this process. And so the hospice medical director said, okay, well, fine, that's a pretty good point. So really, I really did not know if this was copacetic at all, but presented this case, actually talked about this case the next year at the first national meeting, and people like to Quill said, yeah, that's a good idea, I would do that. So I was like, okay, if Tim Quill says that that's okay, then it's okay. And there was this emerging consensus among hospice medical directors at that time that, yes, if a person who does not otherwise have a prognosis of 6 months or less, then says, I intend to do this thing that is legal and I'm entitled to do, and I'm going to follow through on it. Once they have actually begun that process, then it is more likely than not that should they follow through with it, they will have a prognosis of 6 months or less. So that's the rationale for why that patient then became medically eligible for hospice. I will say that he, actually, I think I lied a little bit on this. In real life, in those days, I was a little, nervous about this whole thing, and I thought he needs to really prove that he is medically eligible for hospice. So we're going to admit him on day 3, and then actually, I learned at that first national conference that day 3 is around the time when symptoms really start becoming more troublesome. So we've now changed our policy so that we will admit a patient the day after they've started that process if they weren't medically eligible otherwise. He received medical, nursing, social work, CNA, and chaplain support, the whole package, the whole hospice package, and he died at home surrounded by his family 11 days after he had started VSED and 10 months after his first palliative care visit, and his wife received bereavement support from hospice. That was sort of my first experience with VSED, and it has informed my thinking about it ever since. In many ways, this was sort of the ideal situation. There was a lot of time, there was a lot of education, there was a lot of thought, there was a lot of family support. So what happened? What happened with Robert? What was this? This was a deliberate, self-initiated action by a patient who had decision-making capacity to hasten death in the setting of suffering that was refractory to optimal palliative interventions, prolonged dying that he anticipated and found intolerable, and really he expected deterioration and suffering. And he had an irreversible illness, and he regarded it as unacceptable. He had the classic sort of, met the classic definition of voluntary stopping eating and drinking. Let's talk about VSED and what it's not, because there is a lot of confusion around this. In fact, I just was called about a case yesterday that somebody thought was VSED, and it wasn't remotely VSED, because it was actually, it had to do with a patient who could no longer swallow due to post-radiation effects and had a PEG tube and wanted to stop PEG tube feedings. That was not, and it said, okay, I want to do VSED. That's not VSED. That's a normal disease, that's the result of a normal disease process and the cessation of artificial nutrition and hydration. It's also, VSED is also not what we see all the time, every day in hospice work, which is the gradually declining oral intake as a result of the disease process. It's also not, it's very important to understand that the person would not normally die unless they were to do this voluntary stopping of eating and drinking. It's also not what's called comfort feeding only, which is often requested for patients who have dementia, for example, and who are given minimal amounts of food if they don't seem to want more food and nutrition. It's also, and this is very important, because you'll notice in this last slide, I highlighted that the official definition of VSED is something undertaken by somebody with decision-making capacity. It is also not, what we're talking about here today is not voluntary stopping eating and drinking by advance directive. And that is a whole different ball of wax of a person, for example, who's diagnosed with dementia, and has capacity, and says, when I get when I lose capacity, when I get in more advanced stages of this illness, I do not want to have food. I want food and hydration withheld from me. That's a whole other talk. It's very complicated. It's very complicated ethically. It's very complicated legally, and it's a fascinating subject, but that's not what we're talking about today. This is something that is undertaken by somebody who has capacity. And the final thing that it is not is medical aid in dying. And it's interesting, I was thinking about this term this morning. You know, medical aid in dying is now the sort of descriptive neutral term for what we commonly refer to as, quote, death with dignity, or what used to be called physician-aided death. Now, medical aid in dying is sort of the accepted neutral term. And VSED, although there may be medical aid given in the process, it is not, it's very distinct from medical aid in dying. So let's actually compare these two for a minute, because VSED is people find their way to VSED, I would say probably most commonly when they investigate whether they are candidates for medical aid in dying and find that usually because of prognosis, they are not. So whereas medical aid in dying requires a prognosis of 6 months, there is none specified with voluntary stopping eating and drinking. Also, there's a question of access. As everybody knows, medical aid in dying requires the participation of at least 2 physicians, one prescribing and one consulting. And while the involvement of physicians and other providers is desired in in VSED, it's not required. The average time to complete, interestingly, is about the same. If you take the starting point of medical aid in dying, you need at least 15 days to complete the whole process. And interestingly, the average amount of time that it takes from beginning to end of VSED is around 10 to 14 days. It's interesting to think about cost. Now, with the cocktails that are used in medical aid in dying, the cost is for medications is about $700. The cost for VSED can be nothing, or it can actually be more. And we'll talk more about doulas and how much it actually costs. And Nancy and I were talking about this. It's about $2,000 if you are going to engage a doula for support in this process. The clinical burden. In addition to, so what is the clinical burden of this process? Usually with medical aid in dying, obviously it's low. It's ingestion of a cocktail of medications, and this is a very important difference between the two. The clinical burden, just the physical discomfort and perhaps suffering that occurs with with VSED is generally much higher than that accompanies medical aid in dying. Prevalence. We have a very good idea of what the prevalence of MAID is. The state keeps statistics on it. Anybody can go to the website and see last year, or I think the most recent, 2020 is the most recent number. They had 252 known deaths from ingestion. What's the prevalence of VSED? We have no idea. Because it is not regulated in the same way, it's really hard to, I actually have no idea. I think it is higher than we think, and I think it is going to become even higher than that in the years to come. And then finally, the legal structure regarding whether this is considered, that's not me, is it? No. The legal structure regarding whether it's considered suicide and how the death or not, and how the death certificate should be filled out is very clear. It's written into the law, into the Death with Dignity law in Washington State. I will say it is unclear what it is in the case of medical aid in dying, because nobody has ever codified it. In the clinical guidelines, there will be a recommendation. There is a recommendation about how the death certificate should be filled out. There's endless discussion about what should be filled out. Should it be inanition or dehydration, or should it be the underlying disease? But what is definitely agreed on is that suicide should not be listed as a cause of death, but that's not actually written anywhere in law. So what I always say is, and by the way, this painting is the one that doesn't have an artist ascribed to it. This is actually was in a collection of paintings by patients with early dementia, which I found remarkable. There wasn't a name associated with it, but I thought it was beautiful. I often think that when it comes to the ethical considerations involved, VSED makes medical aid in dying, death with dignity, look like a walk in the park. It can get very complicated for a bunch of reasons. The case that I presented was very straightforward. This was somebody who spent a lot of time, who was very thoughtful, family was on board. He had a very clear, demonstrable decline of a progressive illness. We knew things were going to get much worse. The main principles that are where there's a tension here are those of autonomy, respect for patients' autonomy, versus non-maleficence, doing no harm. By supporting a person's effort to hasten their death by virtue of stopping eating and drinking, are we actually doing harm? And sometimes that is a very easy question to answer, and sometimes it is a very hard question to answer, particularly in the case of untreated mental illness, which I'll get to in a second. Prognosis also makes this much harder in many ways. It is one thing to look at a patient who clearly has a prognosis of 6 months or less and consider whether or not, as a physician, you would participate in hastening their death. And that's not easy, but it is a very different proposition than sitting with a patient who may have a prognosis of years and being sort of party to and supporting of, and this is not just physicians, this is nurses, social workers, CNAs, being part of a person's pursuit of a hastened death. In general, the longer a patient's prognosis, the weirder it feels. Planned death feels weird. There's meant to be some mystery about when a person is actually going to die. That's what we're used to. We've been living for millions of years with the actual time of death being somewhat of a mystery. Anytime you introduce an element of plannedness, whether it's with medical aid in dying, whether it's removing ventilator support, whatever it is, it becomes there's the sense of unease may increase, and I think that's can be very much the case with VSED. The other thing that can make VSED very complicated ethically is that a patient's capacity, while it may be completely intact at the beginning of the process, it usually changes over time. And what may also change is the expression of intent. A patient who says on day one, yes, I'm sure, I don't think this happens that often, but it can happen, and it has happened. I've been involved in cases where a patient says, yes, I want to do this, and they get 4 or 5 days into it and say, no, I don't want to do this anymore. And what is the role of the family who's supporting the clinician, the clinicians who are involved? Is the role to remind them of their intention? Of their initial intention? Is the role to support their current intention? You can see how it can get complicated. And then I think the thing that really, really is increasingly complicated, and we are seeing this as the number of inquiries about VSED increases. The number of patients with untreated mental illness who are investigating VSED as an option is also increasing. I mean, this is what happens when you have a mental health system that's falling apart, and we've seen that too. That is it. To what degree are you actually? Is it actually malpractice to allow a patient who is severely clinically depressed or has untreated bipolar illness who wants to pursue this as a way out? To what extent is it your responsibility to support that versus to make sure that that person gets emergent mental health treatment? That can get complicated. That's why medical aid in dying can look like a walk in the park compared to some of these cases. So that aside, let's talk about initial considerations. Obviously, everybody needs good palliative care. Everybody needs good symptom management. If a person is considering VSED because their symptoms are not being well managed, that is a big red flag that we've got to, let's not even talk about VSED. Let's put that aside and focus on symptom management. That, no matter what, that has to be first and foremost the main consideration. What's also very important is for there to be a clear discussion about what is the expected prognosis without VSED. And it seems obvious in a way, but sometimes people can get so sort of caught up in, wow, VSED and this thing, that they overlook, well, what would life actually look like if you didn't do VSED? To have informed consent in this process really requires that, to the best of your ability, you offer a patient your best estimate of their prognosis without VSED. And then, of course, prognosis with VSED. What is the average? What's really important is to understand that a person's underlying clinical status has a big effect on this. And 21 days can be a really long time. I mean, there's a reason it's really hard to diet. We are driven to eat and drink. It is, so this is not for the faint of heart. This is a big physical undertaking. And then, of course, there has to be an understanding of decisional capacity, which really consists of four components. One, that there's an understanding of the diagnosis and prognosis without VSED, that, as we just alluded to, that there's an understanding of the potential physical challenges associated with VSED, including thirst and dryness on the mouth. You'll hear more about that. And the extent to which they can be managed. They can be managed. They may not be able to be removed. And consistency, and this is very important, and this is why Robert was our sort of poster child for an ideal situation with VSED. Time. This is not to be undertaken lightly, and so showing consistency over time that this is something they want to engage in is very important. And this last one is a little bit nuanced, an understanding of the social and emotional challenges that may accompany VSED. VSED, we are social creatures. We live in families and communities. It is very, very, very hard to consider this in isolation. There are always people around that person. And not all of those people may necessarily see things the same way that the patient does. There may be, depending on the setting, there may be professionals who don't agree with this undertaking. Things can get very complicated, and we'll talk more about that in a minute. So further considerations. What I often say, the most important thing with VSED is people in place. Having people around to support a person through this process is really critically important, because it's an endeavor, it's a process, and people require care. You'll hear a lot more about doula support. Coordination can be a big deal depending on the situation. Where is this going to take place? Who is going to be there? Who is going to be involved? Even apart from the symptom management, people need to know to expect 24/7 care. that's going to be needed for, they need to plan for having that for several weeks. So getting caregivers lined up is very important, and having doula support can be very helpful, especially in the coordination, and hospice support makes a big difference, especially with regard to access to medications for symptom management. And family and friends understanding and support of VSED, as we said, is a really big deal. Along with the religious and spiritual context in which this occurs, it's very important to understand what is this person's faith context. Do other people in that faith tradition understand what this is, support it? If not, why not? What's going on there? This is important to investigate. And then location. Location. This is a very big deal, because as I think you're getting the picture, this is not just about the patient. This is about their family, and it's also about staff. If a patient is in a facility, in an institution where there are staff, there may be a conflict between what a staff person sees as their mandate to offer comfort, which in most cases is nutrition and hydration, versus the patient's and the family's desire for those things not to be offered. So in general, VSED is best pursued outside of a facility, because the intersection with professional staff can sometimes be problematic. Understanding hospice involvement is really important. It's very important if you, say, are counseling a person who's considering this to understand who's the hospice, who are the hospices around, how do they view this, how well versed are they in this. If they're not well versed, don't dismiss them, because a lot of people aren't well versed in this. But what's very important is to understand, will they consider admission early on, or early after VSED has been started. Clear communication, of course, this is with every hospice patient, but clear communication with the patient and family regarding hospice's role. No, the nurse is not going to bring her suitcase to the admission visit, and she's not staying overnight for the next 14 days. And then this last thing is a little bit, this is a little bit of a nuance in discussion of GIP eligibility. So we had the experience, and I'll just be very transparent about this. We had the experience many years ago now. We have at Evergreen, we have an inpatient hospice care center, and we had the experience of a patient who had had a stroke, had gotten admitted to hospice, but now wanted to do VSED. And she was admitted to the hospice care center, and to say that it was the opposite situation of Robert's. To say that she was ambivalent was an understatement. And she had engaged her son to be sort of her advocate, and he requested that when she asked for ice cream, that instead of giving her ice cream in the hospice care center, the nurse should call him, and he would talk his mother out of it. And if she was thirsty and she was asking for water, that this became a conflict, and led to our policy that in general, we don't accept people into a facility at the start of when they're starting VSED. However, it's very possible that a patient may, like any other hospice patient, need inpatient symptom management later on in the process. And that's usually at a time when they've also lost decisional capacity, and a patient can be, and they're not, and a patient can be, usually in the last several days of life, and a patient can be GIP eligible at that point. So, last point here, of course, getting organized is very important. Having a pulse, making sure that it indicates a preference for DNR and comfort measures only, sort of goes without saying. Consider a supplementary advance directive for VSED, saying, yes, this is really what I want to do. This is really my intention, and or a video. And Nancy can talk more about that, but having a video for family members to see, having the person saying, yes, this is really what I want, this is my intention, I think it can help the patient themselves if they want to see that and be reminded of what their intention was. And I think it can really help family, because family can be really struggling with the burden of being present for this. Whoever the person's legal next of kin is or durable power of attorney, making sure that they are on board with this process is very important, because if a patient loses capacity and then the durable power of attorney comes in and says, stop the presses, that's obviously not consistent with the patient's primary wish. I highly, highly recommend connection with a patient advocacy organization. If you are lucky enough to live in Bellingham, and not all of us are, there are many reasons you're lucky if you live in Bellingham, and one of them is that there's an incredible patient advocacy organization, VSED, Northwest, but in this whole state, End of Life Washington actually handles an increasing number of requests about VSED and can provide incredibly valuable support. And then lastly, really consider death doulas, and you're going to hear from a real live one. This is a non-medical coordinator and advocate who facilitates a holistic approach to care, helps to establish the atmosphere, which can be very important, particularly in this case, collaborates with the client, the family, and the care team, and provides education about VSED and the dying process. And so with that, I'm going to turn it over to Nancy.
Hello. Wow. I'm so pleased to be here, and I want to express some gratitudes. First of all, I want to express enormous gratitude to this magnificent woman and clinician. Working with her has just been amazing. I want to express great gratitude to the working group that has been writing these clinical guidelines. You know, David was talking to us yesterday morning, about barriers and boundaries, and the hesitancy for the medical community to support VSED has been such a critical barrier for VSED, for it even being spoken about and explored as an end-of-life option. I need to get some water. I want to express gratitude for this group. Thanks for your interest in VSED, for learning about it, becoming familiar with it, because we need to have these conversations. We need to have these conversations with one another and the people that we work with. We may have real strong feelings about VSED being suffering, and the last thing that we would probably want to do ourselves or to support a family member with. But we will have colleagues who do support VSED and work with a patient, and being able to listen to that person and support them is critically important. And last but certainly not least, I want to express gratitude to the people who have asked me to be their doula. I have learned so much from them, and you're going to meet a couple of them. You're going to have a lot of questions after this, so I'm going to, even though I talk slowly, I'm going to kind of breeze through this information, and I'd rather answer your questions than to give you a whole bunch of information, most of which you probably know. How do I do this? Oh, advance?
Yep.
No?
Yeah.
Other way?
No, that's it.
What's
Symptom
this?
management.
Symptom management?
Yeah.
Oh, okay. Yes, all right. This isn't the slide that I thought I was going to begin with, but we can start with symptom management. No surprise, dry mouth and throat is probably the number one concern because it goes on and on and on. So just scrupulous mouth care is so very, very important. And I have found it really helpful to have a vaporizer, a cool air vaporizer, right by the head of the person and have it going all the time. This is also something that I practice with people ahead of time. I have found practicing ahead of time really, really is important. Handing them a toothbrush and saying, okay, you're getting, perhaps you're confused, but you know how to brush your teeth. Show me how you would brush your teeth if you didn't have much water in your mouth. And brush your tongue and brush your palate. We experiment with that. Using a aerosol spritzer on one of those little blue bottles with water, very sparingly, but certainly being able to give that to a person to freshen their mouth. Hunger isn't much of a concern with the clients that I have worked with. It's anecdotal. I don't know if decreasing calories ahead of time makes a difference with shrinking the stomach. I would love for some nurses here to take this on as nursing research. But with the people that I have worked with, it seems to have helped that a week before their beginning date, that they begin to decrease, not their fluid, but to decrease the amount of food that they take in, especially protein, and just really cut down on that. Constipation and cramping, I think, has been a major concern, and for that reason, I encourage the people that I work with to do a colon cleanse, to really clean out their gut so that there's nothing there to start rotting and creating gas and discomfort, and to distend their abdomen. Again, a colon cleanse is not going to be in the guidelines, and please do the nursing research and study, because I think it would be valuable to figure out if that's really helpful. Sore muscles. We've all been sick. We've all been in bed, and our bodies get really sore. So that's a major discomfort, and certainly massage and repositioning acupuncture are all helpful things. Fatigue and weakness, no explanation. It happens. Loss of balance, certainly. Dehydration, you're going to be wobbly on your feet, and you're going to be confused. So the medication, but mostly I have found, especially in the first phase of VSED, that reassurance, distraction, just so very important. If a person becomes truly agitated, medication and one's presence, compassionate, reassuring presence, and hallucinations, obviously medication. I figured it out. Think for a moment about the meal that we're going to have in just a short while. What pleasure, what comfort, what do we get from eating? We get the taste of food. We get the stimulation of our jaw movement. We socialize. We get nutrients. The taste sense up there is the one of 5 senses that is kind of blocked out, because that's what our patient loses. And it's huge. And it means that the person is deprived nutrition and stimulation, but not necessarily socialization. So it's important to focus on the other senses in order to distract the person. One of the things that I have found really helpful is to, during the pre-start days, during the preparation days, to give a client a whole list of possible things that they might find comforting or pleasurable for them, and have them check it off and add their own. And it's also a wonderful thing for people to do with their family members. Preparation of the heart and soul is so important. Relying on that comfort list, sharing it with caregivers, sharing it with family. These are the things that could help. Please be able to play this kind of music. Come bring your guitar and sing. Let's tell family stories. Yeah, have the neighbor come in and talk about what's going on with their grandkids. These are valuable things and valuable distractions. Having a focal point could be having the bed by the window, something to look out into. Pets, you can read the list. Just wonderful, wonderful things that are distracting and comfortable. Here's another question for you, though. Does it sound like a birth plan? Some of you are my age, and so you're familiar with the 70s and 80s, and those of us in pregnancy preparing our extra long birth plans of all the things that we wanted. It's so similar. It's so similar, and I draw all the time on my experience gained as a labor and delivery nurse, but particularly as a birth doula. Environment is critically important, and I tell families to make a nest. Where in the house do they feel most comfortable? Do they feel most at ease? And again, you can look at just something of beauty, something of comfort. A place for a visitor, a place for a pet. Helpful supplies, you can read the list. The little bottle, squirty bottle with the squirter on top, lip balm, all kinds of mouth care. You'll see that many of these relate to mouth care. Any kind of creature comfort could be a supply. Have people practice ahead of time using an incontinent product. You know, I have them pull up a diaper. You could say, I'm wearing one too. You know, just let's try it. So that when it actually happens, that it's not a surprise. And everybody can be comfortable with it. let me quickly talk about the 3 phases of VSED. For those of you who've been through the birth of a baby, you remember that when contractions start, you get really excited, like, whoa, it's happening. I wonder what this is going to be like. My experience with the people that I've worked with is that after they have done all of this incredible preparation, they've prepared themselves legally and financially, they've consulted hospice, they have found a caregiver who is supportive, they have found caregivers with the help of a death doula, perhaps, and have their home prepared. They're all set. Their begin date is here. Family is and other support systems are around them. They're so excited. They're animated. They want to get on with us, with it, and it feels like, oh, I can do this. I can do this because I'm prepared for it. And my job as death doula, now that I've helped prepare them and coordinate all the other services that are involved, my job, I see, is to be with them, but to slow things down. It's a beautiful time for getting together with family, being with family, feeling the love, taking it a day at a time. Middle phase, and I'm going to show you pictures of these. Middle phase moves into the more adult phase. The more difficult stage. Similarity to birth. I'm going to refer my clients to the birth process because I see so many similarities. You know, when the contractions first start, you get excited because, whoa, baby's on its way. When the contractions have been going on 2 or 3 hours and you didn't want to have the epidural, it's like, oh my God, this is kind of hard, and I can anticipate what's coming, and I'm not sure that I like what's coming. And that's exactly what happens in the mid phase of VSED. It is hard. It is hard work because of the discomfort, of the confusion, of the loss of balance, symptom management. Thank God can be helped with either holistic medicine or medication, and family and other kinds of support are absolutely critical. Late phase is the phase that you all are familiar with. Patient is actively dying. They're in a coma. And so the focus is really moved to care of this body and positioning, and then focus on the family and the support system. I'm going to be real brief with this story, but I learned so much from this woman. This was the first case that I had entirely on my own as a death doula. This is Jane Vander Weeden and her husband, Dick. Just an amazing, amazing woman. She was a hiker, she was a philanthropist, she was a writer. Her mother had died of Alzheimer's, and she said to her family, as she approached her 70s, if I develop symptoms of Alzheimer's, I want to end my life. I am not going to go through and put you through the stages of Alzheimer's, nor am I going to put you through it. When she began to be a little irritable at night and a little confused, they reached out to Wechkin Hospice, and said, okay, this is something that's happening. Could we explore VSED possibly with hospice? They checked in with a doula service that was available at that time, but family was not supportive of her excuse me, her daughter and her husband in particular were saying, you have grandbaby girls, we need you to be here. I'm going to speed up the story a little bit. She ultimately got the diagnosis of dementia and of Alzheimer's, and contacted me, and because she had done her work ahead of time, knew about VSED, had contacted an attorney in town who was supportive of getting legal stuff in town, lined up for her. Her family physician was supportive of VSED. Amazing. So we found her caregivers, and I talked with them about the phases of VSED, and she began. And she died in 9 days. And I have, it was such a learning for me in that it was picture perfect. Family was totally there to support her. She interacted with her grandchildren. What other? She was, sorry, I'm just kind of touched. It went really well, and it doesn't always that. This family made 2 videos, made a long video for legal purposes to say, this is what my decision is, this is why I'm doing it. And they made a short video which they used in the mid-phase when Jane became a little confused. She had a 60-second video on her phone that said, Jane, this is why you have decided to VSED. Please stay with it. I have a policy with clients that I tell them way ahead of time, part of the important preparation, that in mid-phase, they can change their mind. And they can change, so they don't have to do VSED. It's totally up to them. I'm not going to stand over them and insist that they do VSED. What I do when we practice this is that if first time they say, I think I want something to drink, please, my response is to say, I'll get you something to drink if that's what you really want. But let me remind you what you're doing and what you chose to do. And maybe it would be helpful if I just gave you a little sprit of water and we did your mouth care. And let's try some lotion on your face. And let me have your daughter come in and talk to you some, just to distract you. That usually works. If she asks a second time, I say, let's have Dick come in and talk to you about this decision. But in the meantime, let's refresh your mouth. The third time, if she comes in and wants to be given water or food, we play the video. And if she still wants, we end it. Quick outline of the early phase. I already told you about it, sorry. Everything's ready. The cleanse, the enema, or the intestinal cleanse has been done. Everybody's excited, and hopefully a hospice has been notified. This is a picture of Jane on day 2, I think, actually. They're watching movies. She's in her 90. She spent the night before in the same bed as her husband, but she napped in the hospital bed. I asked her to please use the hospital bed because it would be easier for caregivers, and she obliged happily. But I said, you know, you can ease into using the hospital bed. The early phase but the end of the early phase, hospice was involved. She got tired easily, surprise, surprise. There were certainly safety issues because she was wobbly, and so important to do the humidifier and to give her small doses of morphine. We had discussed ahead of time her level of sedation, and she said that she wanted to be able to interact with all of her family members until she was either so uncomfortable that she couldn't concentrate on those conversations or had gone into a coma. Oh, right. We're at noon. Oh, gee. Okay, we're going to speed it up. These are pictures of Jane. Middle phase, agitated, a little agitated. Longer periods of sleep, becoming confused, dehydration, medication. Late phase. Body's transitioning as her body systems are shutting down, goes into a coma. Hard picture to look at, but there she is. And like I said, she died in 1980s. Part of my role as a death doula is talking with a family about after death. And we had a leave-taking little ceremony when her body left the house. These are the important resources I wanted to make sure that you all knew about. The VSEDresources.com is the website for the new nonprofit in Bellingham, VSED Resources Northwest. It has fabulous information about VSED. End of Life Washington also is an excellent website, and that's www.endoflifewa.org. Choosing to Die is one of the first books that I became aware of regarding VSED. It was written by a Bellingham person, Phyllis Schachter. Phyllis also has a wonderful website that has great information about VSED. Phyllis assisted her husband, I believe in 2009, 2010, to use VSED, and they are real pioneers because there was nobody to support them at that time. And this book, the VSED Handbook, is a book of resources and that Jane's daughter wrote, and it's $15 is a good deal, and $5 of it goes to VSED Resources Northwest. I thank you for your time, and we're going to take some questions.
So a question for Hope. If a person who previously didn't qualify for hospice can become qualified because they stopped eating and drinking, and if that were to continue, they would die within 6 months, etc., then why couldn't they automatically qualify for aid in dying at the same time?
That is a very interesting question. In practice, a couple reasons why that doesn't happen. First of all, the process of the legal process actually takes longer than VSED. If you had everything teed up, the shortest amount of time that you can accomplish medical aid in dying is 15 days. The other thing, though, is that, but it's an interesting question because, because as we've heard, there's a huge physical burden associated with VSED that is not there with medical aid in dying. The problem is the underlying diagnosis. The physician, you're not going to get a physician to say that this person has a terminal illness because they're going to start doing VSED. That you have to, in order to qualify for medical aid in dying, you have to have, at the time that you're starting the process, a prognosis of 15 days or less. So I mean, practically speaking, it's hard enough to get physicians to participate in medical aid in dying when there's a clear prognosis. I think that would be seen as not the way the law was intended. I'm interested to hear what other people think about that, but I think that would be seen as that's now a misuse of the way the law was written.
Can you speak to legal issues such as status, immigration status, or past felonies?
Can you come back. I feel like there's more behind that question.
Would there be a certain category of people that you as a practitioner would not consider because of legal status issues?
Oh, what an interesting question. I don't think so. I don't think, in my mind, the people who I would not, who give me pause is when there's untreated mental health disorders. That's really the problematic. Either untreated mental health or prognosis that is so long that I have to say, Jane's case would give me pause. I'm not saying I couldn't get there, but it would give me pause because she has, as I said, the longer the prognosis, the greater the greater the complexity. Jane's case is different than Robert's case because Robert was much more debilitated at the time that he started VSED, and that matters. But immigration status, criminal history, that doesn't figure into it at all in my mind. Yeah.
From a pediatric standpoint, decision-making capacity, and I know Bob McCauley, who's a dear friend, was on that, but I'm just curious if you can talk.
Oh my gosh. So there's medical aid in dying, and then there's VSED in adults, and then there's VSED in children. In terms of complexity, I think I don't even, my jaw's dropping at thinking about the complexity of that. I mean, I think it's hard. I am not aware of any pediatric patients who have done VSED. I have a hard time wrapping my head around that because I think a very ill child who is wanting to hasten their death that's going to get very complicated very quickly. Again, with this question about mental health, are they getting adequate mental health treatment? That's a frontier. I don't know. Maybe do you have? Please say more.
I don't have any info about that. I guess I'm just curious. Would we consider it like we would consider medical aid in dying, like that decisional level of legally would, if they're eligible for one, they would be eligible for another? I'm not like a big proponent of any of this. I'm just curious.
No, I think any pediatric ethics committee would have a big struggle with that. And never say never, but I think it's hard to imagine.
Just as an FYI, because I work at Seattle Children's, we are a division with bioethics, so we partner very closely all the time.
Right.
I just was curious if there was any
I will
literature or information.
Yeah, I will ask Ross Hayes if it's ever come up, but I'm not aware of any cases.
Thank you both so much. That was a great talk. So much richness. My question was about, sort of related, was around decisional capacity. So in the case of Jane, for example, if Jane had lost capacity before she decided this is the day, is that something that her decisional surrogate could do? Could they make that decision to start?
Basically, no.
Okay.
Yes. See, that was a black and white answer. No. By definition, it requires capacity.
So a little piece of Jane's story that I think might help is that Jane had over years made clear her intent. So I think that helped the physician support this decision, because it was not I think I'll VSED. She had made it very, very clear over quite a number of years that if she got dementia, this was going to be her choice.
Thank you. Yeah, I think that matters. I think that matters a huge amount. Having that time, that relationship over time, that's very different than somebody just showing up on your doorstep saying, "Okay, I want to do this." Go.
My question is about the nitpicky detail of what is going to go on the death certificate as the cause of death. If the surviving spouse is going to rely on life insurance, for example, and if suicide on the death certificate could negate that, I mean, do you have to counsel people about checking that out?
Well, so in the clinical guide, so we address this in the clinical guidelines. Okay. The recommendation is that the cause of death be either, I generally will, I would write inanition secondary to PSP in Robert's case, or in Jane's case, I would write, inanition, dehydration, something like that, and I would list, and I would list Alzheimer's dementia as, one of the secondary or tertiary causes. There's no problem with life insurance with that. I don't know of any physician who has ever actually written suicide as a cause of death, but but you don't want that doctor involved in filling out your death certificate. Anyway, so yeah, but that would be very much flying in the spirit of what is being undertaken here. My only point is that it is called out specifically in the law of death with dignity that the cause of death shall not be, ingestion of a lethal dose of medication. The cause of death shall be pancreatic cancer or whatever. And there's no such clarity in any directions about VSED, and that's part of what we're trying to address with, it's not the law, but it's something, it's clinical guidelines. And then the hope is that becomes standard of care, so that it is standard of care that dictates that you can go to a physician and say, the standard of care is that the cause of death is listed as inanition or dehydration. Oh, yeah, yep. Thank you.